Okay, we're coming back to order today. I want to thank everybody for coming here. We had some discussions earlier today, and so as we were going through, we believe that improving the healthcare in the Indian country is going to go a little bit longer than the hour. It's hard to sit with just one of these agencies with the questions that we have and get them all out and have good dialogue in 1 hour, but we have 4 of them put together. So we're thinking that it could potentially run over. But we have a hard stop at 10:15 so that we can move into the Great American Recovery Initiative with the White House. Saying that, our panelists have agreed to come back and stay at lunch. And so if we need to carry this conversation over at lunchtime, we will. And so that's how we respond to that. And so I hope everybody can make it through the day. Got to be a little hungry, but I think we're going to be able to do this in a good way. Unfortunately, it's my understanding that Acting Group Director Jessica Steffens has a hard out, and she will not be back. And so what I would ask, knowing what I just said, that any questions that we have early on be directed to Ms. Steffens, and then we can move forward with that. Any questions? Okay, thank you. So why don't we go ahead and get started this morning? And would somebody like to open us up in prayer? Please do. Go.
As leaders and as the Spirit entered the room to guide us in the right direction for the health and safety of our communities. Umbi agende banawe o chutan herindi anande waba baikin akuta on a hin champo ne wawi wegeja dagin hana ke when bo we sikipuri we sekanapuri ho ho we wats in mo pink pia sampia akompia tampe o pake nasunungi inge un tamawako haje ne wawi tseho e nu anyu tarajia namu wagri newe baikin a champ mo baikin akin ko wagri we wegeja ne wawi Washington hanamu wagri newe ne wawi angsha we sotum pave namu hiwana pundiri hiwana sogeri ne wa oti he ha han sankari ne wa nami sedo and kuyo mu we mangeri ta kiribit ori ma na we tono enji mu we watsi again ihui poke hoke yake jake oti he ha han sankari baikin a kunda pona hin champo ne wa pinta hari hata hari newe ne wawi tungjong hanamu we hapo ongepe ne wawi angsha namu baikin akunda pona hinchampo sengwa kuya wenuri sengwa kuya biha ne wawi angsha na ta namu wagiri ne wa baikin akunda po pinkpe tsampe akompe tampe o pake nasunungi inge ne wa tamawa ko haje we khambo chano hiwana pundi hiwana sogiri witse ho e nu anyu tarajia namu wagiri newe we boy Jono wants to any hingonka. My blessings to all of you. So have a good day and God bless each and every one of you. Thank you.
Thank you. I'd like to introduce to you Acting Group Director Jessica Steffens. We also have with us Administrator Thomas Ingalls. And we have here with us today Acting Director Crocker for Crystal D. Carroll, Principal Deputy Assistant of SAFSA. We want to welcome her, and also Mr. Fulton, the Chief of Staff at IHS. With that being said, we do expect this panel to last a little bit longer today, and we appreciate your willingness to come back after lunch if we need it, because we have the hard stop at 10:15. I'd ask you to keep your opening remarks short, as we are expecting quite a few questions. That being said, thank you, and thank you for being with us today. And who wants to start? Yep.
I'm happy to, and good morning. Thank you, Chairman. Thanks, panel. I'm Jessica Stevens. I am, as you just heard, Acting Group Director at the Center for Medicare and Medicaid Services in our CMCS, which is our Medicaid and CHIP Center. I had the pleasure of speaking with the TTAG, the CMS TTAG, it was just last month, and I'm looking forward, thank you, Chairman Allen, for the opportunity to share a little bit today with this group as well. Recognizing that I know there are a lot of questions, I will just say at a high level that we are doing a lot at the moment, really focused on a number of key initiatives across the government right now. I know one of the things that there's significant interest in is the implementation of HR 1, OBBBA. I know it has many terms. Generally, we refer to it in CMS as the Working Families Tax Cut legislation, which includes a number of provisions related to healthcare. They relate to sort of eligibility, cost sharing, fraud and abuse, ensuring that healthcare is available for vulnerable beneficiaries. In particular, my team is responsible for implementing a number of the provisions which have important exceptions for American Indians and Alaska Natives, and I'm happy to talk a lot more about sort of what we are doing, both to ensure that those exceptions are implemented and to ensure that those provisions where there are no exceptions are implemented in an appropriate way. Of course, that includes the work requirements or community engagement, increased redeterminations to 6 months, and cost sharing. All three of those are areas in which American Indians and Alaska Natives are exempt. We have put out a good amount of guidance on some of this, although we are working on more, and working in collaboration with the TTAG. We are planning to issue more specific guidance on the ways in which states are expected to implement to ensure that individuals in Indian country that the exceptions are implemented appropriately for individuals in Indian country, and that we continue to ensure that healthcare is available, accessible, and that the funding continues to flow. I'm going to stop there, knowing that there are a lot of questions, but I will turn it over to my panelists. Thank you.
Thank you, Mr. Joseph. Good morning, everyone. Seal, good to see you. It's great to be with a lot of you again. I think many of you, we've had the chance to engage over the recent months. I think, first off, just want to thank the Secretary for his support. I think you really see that in this budget for the Indian Health Service in FY27, and we're very excited to see those increases. As we look at the Indian Health Service and we ask ourselves what's important, there are several things. One is making sure we're continuing to provide high-quality care to every patient that comes through our doors. But the other is making sure that we're doing our role in implementing ISDIA and supporting the self-governance acceleration that we've seen across the system. As you know, roughly $3.2 billion are administered through tribal programs under self-governance compacts each year through the Indian Health Service, representing about 65% of the programmatic funding of the agency. Additionally, you'll notice that we've continued to completely support fulfilling all the obligations we have in adjacent to that, specifically contract support costs, 105L, that we've seen rapid increases for over here. We're currently looking at about 1,300 105L leases occurring across the Indian Health Service, and we expect that number to continue to grow as it has each year moving forward. So we're very excited to continue to support moving forward with keeping those fully funded, as you've seen in at least the FY27 budget. Additionally, we're going to continue to do what we can to fulfill our court-ordered and statutory obligations, continuing to resolve CTA claims, rolling forward with implementing the guidance that we've received recently moving forward. So it's a good time to be at the Indian Health Service. I will keep this fairly short, but as you know, we're continuing to advance in a number of key priorities. We're trying to be receptive, trying to hear. That's why you're seeing, continuing to work for advanced appropriations and the impact that has, and proved detrimental this last year. So you'll notice that in this year's President's budget, and we plan on continuing that forward. Appreciate it.
Mr. Ingalls.
Good morning, everyone. Thank you, Mr. Chairman. My name is Tom Ingalls, and I'm the administrator of the Health Resources and Services Administration, and it's great to see so many familiar faces. The nice thing about coming to these on a regular basis, I get to see some great friends. And I really get to see some of my great friends from my home state of Wisconsin that I'm going to have a chance to meet with, the Lac du Flambeau tribe, later on. I just want to say I really appreciate this opportunity because we can continue our government-to-government relationship and listening sessions. It's important for me to hear what's important to you. I want to make sure that we're working together. So does Secretary Kennedy. So across our nations, as we're working to build this relationship, I want to continue to work on areas, for example, the National Health Service Corps. As you know, HRSA has a $16.9 million set aside in the National Health Service Corps program. We want to make sure that you're well aware of that and you're taking full advantage of that opportunity. Earlier this month, I had a chance to go down to Phoenix and with Devin and Mark Cruz, and we had a chance to visit with staff in the Native Health program in Phoenix. I was really impressed what I saw there and on the great working relationship that they have with Phoenix and the tribes in that area. And I did come back with some Navajo tea that I really like, and I think it was called Blue Mush, and I really like it. I think I had 4 or 5 bowls of it. And it also want to make you aware, we do have a maternal health program. And one of the great things about our maternal health program is we have a hotline that I encourage all of you to make sure that your members know about. It's 1-833-TLC-MAMA, TLC Mama. It's available 24 hours a day, 7 days a week, and it's for anybody that knows someone that might be battling depression, a young mother that might be battling depression, or just doesn't know what to do. Reach out with that hotline. They are there for you. They are there for your members. Finally, I know you all want to talk about the 340B program. The comment period just closed on Monday. We're reviewing those comments. I know that there's been a number of comments made by tribal representatives across the country asking that an exception be made. We're taking a look at that. Can't make any considerations right now at this time because we want to review all the comments, but we're going to be reviewing all of those. I'm here to listen to you. You're not here to listen to me. I'm here to listen to you. If we can answer your questions, I want to find ways to work together. Thank you and welcome.
Okay. Good morning. First, I would like to start by saying how honored I am to be here this morning. I am here on behalf of Chris Carroll, who is the Principal Deputy Assistant Secretary for SAMHSA. My name is Odessa Crocker, and I'm the Acting Director for the Office of Financial Resources. And my opening is going to be just a little bit long because I want to be true to express how our PDAS feels about not being here today, and I want to be able to convey the message that he wanted to be able to share. So I'm going to be reading a message directly from him. I would like to start by saying thank you all for being here. We deeply value your leadership, your trust, and the open and honest dialogue that we have. At SAMHSA, we lead the nation's public health resources, programs, and policies. Our role with the tribal nations is grounded in respect for tribal sovereignty, partnership, and a commitment to improving behavioral health outcomes in Native communities. We engage in regular consultation to ensure tribal voices inform policy and programs, while also providing training, technical assistance, and data support. This annual budget and policy consultation is one of the most important gatherings to help us learn more about your needs for the year ahead. Secretary Kennedy often mentions he's committed to upholding our unique relationship with tribes and respecting cultural health and healing interventions and practices. Much of this agenda focuses on this administration's efforts to actively reform America's food, health, and scientific systems. It's designed so we talk through the new approaches we're taking, like investing in infrastructure, incorporating traditional foods into federal nutrition policy, and expanding how we address addiction through what we're calling the Great American Recovery Initiative. At SAMHSA, we are carrying out the Secretary's vision of working towards long-term health and wellness by looking at where we can address the root of behavioral health problems. We absolutely want to do more than just connect Indigenous peoples to behavioral health support and services. We want to help people heal holistically, help communities recover, and end the devastation that addiction, overdose, or untreated serious mental illness can cause. Although we recognize we have a lot of work ahead of us, we are pleased to see the meaningful progress since the start of this administration. For example, in fiscal year 25, SAMHSA has funded 424 tribal nations, communities, and organizations, a total of $211 million in investment. For our current fiscal year, SAMHSA is forecasting to release 51 funding opportunities, or notice of funding opportunities, that tribal nations and organizations will be able to apply for. Some of these, as most of you are probably familiar with, include the Tribal Opioid Response Grant, our Zero Suicide in Health Systems program, the 988 Tribal Response Grant, and the Community Mental Health Initiative Grant Program. In keeping with our commitment to tribal nations, we see continued support for behavioral health programs, support, and services with the President's 2027 fiscal year budget request. Before I turn the floor back over to the chairman, I want to be sure that I convey on behalf of SAMHSA, it is very important that we continue these open conversations so we can hear from you and strategize how we can come together to address the behavioral health needs in our communities. I thank you for the opportunity to be here, and I look forward to hearing your questions and feedback.
Thank you. I'd just like to take this opportunity to ask, do we have any questions that we'd like to direct to Ms. Steffens at CMS? Mr. Allen, Chairman Allen, please.
Thanks, Mr. Chair. Jessica, good to see you again. So we have a number of asks, these keep rolling over, these same questions with regard to CMS, TTAG, and STAC, and the budget issues. So a lot of these questions are targeted at the resources essential for success. So in no particular order, the third-party revenue, as we have said to you guys numerous times, from Medicare, Medicaid, CHIP programs, et cetera, are essential for us to be successful. And so it is very tough for us to be able to provide the kind of quality services categorically through the different programs that we provide to our citizens. So I just want to make sure that we emphasize the need for a work group to work with CMS leadership on implementation of HR 1. That, all the exemptions and so forth, that needs to be identified and processed in a way that is clear throughout all the states and the system. So that is critically important. It is also important that we make sure that you are supportive of receiving the OMB all-inclusive rate for the tribes, FMAP, with the states, et cetera, and also that it applies to urban providers as well, because they serve so many of our tribal citizens throughout America. The issue also is we want to make sure, in the past administrations have provided for the tribal, I'm going to call it the Division of Tribal Affairs, which is underfunded and understaffed. back in the day when we were trying to implement all the different provisions of ACA, and now moving forward with regard to HR1, et cetera, there's a lot to be communicated out there. And we were at the $7 million range. We're now just hovering just over $2 million. It's not enough to be able to reach out and communicate and educate all the tribes, all the 575 Indian nations throughout America. So that is critically important. Getting that staff upgraded to the current level of need of 7 is really important. The TTAG budget itself, it's relative to implementation of our priorities. We've identified a number of different priorities administratively that we think you have the authority to be able to implement that help us move our agenda forward with regard to the CMS programs. And so we urge that administratively that we talk through. That's why the work group would be helpful, not just HR1, but also how we're going to be able to move that agenda aggressively forward to be effective in our respective communities. I will say that this kind of overlaps into SAMHSA. Behavioral health is an example. For us to be able to put together programs for behavioral and mental health problems with regard to inpatient, there's not a lot of resources out there. So third-party revenue is revenue that we will use to leverage our ability to be able to provide those kind of programs. I'm doing one right now. In my area, there's only one in the area, and we decided to make the leap, $32 million for 16 beds. And I guarantee you they'll be filled once we open up this coming fall, and because of that urgent need. And so it overlaps. So you talk about the need, but I can tell you it's expensive. My psychiatrist that I had just negotiated, $350,000 a year. They don't come cheap. So, and that's just one guy, not even counting the counselors and nurses and specialists that are essential for those kind of programs to be successful. CMS is essential to be successful here. And so we urge that we work with you. The one last point I'll make is that not all states are alike and tribal state friendly. And so we need CMS to be more aggressive about communicating with regard to the exceptions and the exemptions that are relative to the tribes, and we need help. We know you only have so much authority, but you can nudge them in a direction that gets them a more positive relationship. So I'll just throw that out for now, Mr. Chairman. Thank you.
Thank you, Chairman Allen, Mr. Allen. Appreciate all your comments and to see you again. Going sort of area by area, in general, I wanted to maybe start off where you ended, which is we are committed to implementing the protections, not just in HR1, even though I know that those are particularly important, and our work group is working closely with the TTAG, and we are committed to providing tribal-specific guidance in the not-too-distant future that helps to ensure that the protections are clear, that we are working closely with states, and that we can do what we can do to urge states to implement both the exceptions but also the provisions in a manner that helps to ensure that individuals who continue to be eligible for Medicaid and CHIP remain eligible and enrolled, so that, as you refer to, the third-party resources continue to flow to be able to provide the care that is necessary. Sorry.
Well, I was going to, one last thing, and this overlaps with Clayton over the IHS. The Indian Self-Determination Education Assistance Act clearly authorizes us in terms of implementing our programs with regard to benefits, which is the tribes, tribal citizens, and non-BENs in our area. The non-BEN side, and those areas that will serve them, helps us generate that revenue. We need the administration to be supportive of it. The act, quite frankly, I think we often refer to it as Section 813 of the act. It's authorized. So talk to your damn lawyers, because those guys are interpreting it narrowly, and we want it to bring broadly in the interest of Indian country. We know that there's some challenges out there. okay? But they're anomalies and they're not the norm. And we are a big part of the problem, a big part of the solution for Healthy America.
Thank you for that. I have taken note, and we'll talk to our lawyers about that. I want to go back to one of your other points that you made too, which is around both our staffing and our ability to provide sort of ongoing support and implementation of all of the provisions. Recognizing the Division of Tribal Affairs, yes, is in the group that I currently oversee. I know we've had some conversations and appreciate your continued sort of push and advocacy to ensure that we have at least the minimum staffing that is required to continue to provide the support that is needed across not just Medicaid, but Marketplace and Medicare coverage. Our leadership is committed to staffing up and providing resources to ensure that we can achieve all of the things that we are doing. In the meantime, I do want to continue to express my own commitment to the team to help provide both the support and the resources that are needed to help keep this work going. And that, of course, includes not just being able to ensure that the HR1 implementation goes smoothly with all of the exceptions and the protections, but that we also continue to demonstrate sort of our commitment to tribal sovereignty and our partnership in ensuring that healthcare is available throughout Indian country.
And Victor, forgive me. One more. I don't know who implements with CMS on the rural health initiative, the $50 billion that's out there, $10 billion a year, to ensure the guidance to the states regarding making sure that tribes have access, fairer access to those resources. It's varying from state to state in terms of, because the money's going to the state, and how much are they sharing with the state, with the tribes regarding, how that program is going to help those rural hospitals, community hospitals that are critical to many of us who do not have hospitals.
Right, and we know that many states included tribes in their applications for the Rural Health Transformation Programs. We also know that tribes want to ensure that the $50 billion, the rural health, for the Rural Health Transformation Program, that Indian healthcare providers receive access to those funds. There's our team, the team that is implementing the Rural Health Transformation Program is out in the field and is committed to ensuring that in the state visits that they're doing, that they are meeting with leaders in Indian country in all the states that they visit as part of the way to ensure that those funds, both the initiatives have a positive impact and that the funds flow. So more to come on that. Thank you.
Ms. Yaji.
Thank you, Chief. Good morning. On behalf of the Navajo Nation, as you know, the Navajo Nation has a very diverse healthcare system. And within our healthcare system, we do have 638 functions that are co-occurring on the Navajo Nation. And we just want to, case in point, want to bring to your attention that our treaty obligations are government to government and not with states. So I think it's important that you speak directly with the nations and not with the states. That's critical in terms of understanding what the true needs are, just like my fellow colleague here, Mr. Allen, stated. Every state is different in how we work with them or how they choose to work with tribes, nations, and pueblos. But it's imperative to understand that when the funding is funneled down for Medicaid, that it's government to government. And so tribes, nations, and pueblos should have that consultations in terms of how the discussions and how we should move forward with our funding. And if that doesn't happen, consultation isn't happening if it's just going directly to states, because our treaty obligations aren't with the states, it's with the U.S. government. Thank you.
Chief Harris.
Good morning, Mr. Stevens. How are you doing this morning? Hope you are welcomed here today. So my name is Brian Harris. I'm the Chief of Catawba Indian Nation. I'm also a Nashville area representative of USET. And so I have just one question here for you this morning to see if you can expand on this. As you know, the Office of the Inspector General, they initiated an audit for Medicaid claims reimbursements under FEMAP. Well, tribal nations, we never got a clear picture of the how and the when and the where that's going on. Can you kind of update us on that aspect of why that audit was issued under those circumstances?
So the OIG is independent of CMS. So I cannot speak specifically to sort of the reasons and the rationale for the specific audit. I am aware, though, of the audit. I think I can go back and see what additional information we can obtain that we can provide.
Can you give us any high-level, just any kind of high-level overview of what you know?
I know very little, I will confess.
Okay. Thank you, ma'am.
Thank you.
Councilmember Glutz.
A couple of quick things that I want to talk about a little bit about the rural health money that's going out. Much of Indian country is in rural communities, and the rural hospitals are generally not these big hospital corporations. But when the rural health money flows into the state, who do you think's trying to get at the table? The big hospital entities that form the advisory stuff. They're trying to suck up the money. They're trying to suck up the money and figure out, and they're saying, hey, we can come to the table because we know how the hospital systems work, but the money really needs to flow. We need to watch this carefully. The money needs to flow to the tribes, and the money needs to flow to the real hospitals that are at risk of going away and decreasing our access to care. And so these big hospital corporations that are trying to get their fingers in this pie, I want you to make sure you watch out for that and make sure that's not happening. Secondly, the demonstration project for the urban programs to have 100% FMAP went away, and the urban programs serve many of our people. I have a 101-year-old Yakima mother that is served by an urban program. She's away from her tribe, and she's being served by an urban program. And so the urban programs are very important to make sure that we make sure that they continue to have funding. And I had one other thought that I lost, and I'll just be quiet since I can't keep my memory together here.
Mr. Bunch.
Thank you, Mr. Chair. I'll keep my comments brief, but I wanted to chime in on the issue with the states and the pass-through monies that go through the states. I want to ask this question, first of all, is can we work on a mechanism for tribes who are interested for direct funding instead of the money flowing through the states? That's my main question. For instance, the Cherokee Nation is located in the state of Oklahoma's boundaries. In the state of Oklahoma, the legislators are currently actively trying to scale back on Medicaid expansion, and that leaves the 30-plus tribes in the state of Oklahoma in a bad position. Even though the federal government reimburses at 100%, and it does not cost the state for the tribes dollars, that would directly impact the Cherokee Nation alone for roughly $165 million. We have to find a way to have a better process and get direct funding for the tribes. So please consider that. Thank you. Whittle.
Please, if you can respond.
Thank you. I think we will take that back and take it under advisement. Thank you.
Please.
Good morning. Thank you, Chairman. I'll keep my comments short. President Biden, in the ACA, is allowable for tribes or Indian entities to create and stand up Indian managed care entity to carve out the Medicaid percentage that goes to the state and manage our own health care ourselves. We in South Dakota have established a coalition of tribes to do just that. But what we're running into is barriers, of course, red tape and things like that. My understanding is by 2030 is that all healthcare will be managed care entities. And so we as tribes in South Dakota wanted to get ahead of that, get established and put that into place right now. And we are working with the state, who is all for this, because in that first year, our state will save $200 million just by carving that out and giving that to the tribes so we can administer it ourselves. We can really use your support and help us to get this to the goal line. Thank you.
Thank you. I just wanted to add on to that, the behavioral health funding through the state IGA process, because we received that money through the state, that we should look at a process, just a recommendation, a process to work to remove that requirement, that the tribes must work through the state system in order to receive federal funds. This would only ensure better tribal control of funding, but it would provide tribes better ability to enforce quality controls. Currently, tribes do not contract with Access, which is the state Medicaid vendors, and have very little control over critical service and quality assurance for that quality issues. So thank you.
Thank you. I'm hearing a theme of asks and responses here, and so I will make those connections and take them back. Thank you.
Good morning. Thank you for being here today. Herminia Frias, and I am councilwoman for Pascuayaqui tribe in Tucson, Arizona, and all throughout Arizona, actually. But the reservation is in Tucson, at least one of them, both of them. I just wanted to bring up the issue with CMS and, some of the things that were highlighted already about each state is different, and some of the challenges that we've experienced in Arizona because of the fraudulent sober homes. And in this case, you had these fraudsters that were standing up these supposedly sober homes that were not that at all. And a lot of our citizens, community members died in those homes. And so that has created a, well, first of all, it's a big loss for our communities. And now, as we continue to provide behavioral health services, it has created a disconnect when it comes to contracting with behavioral health services, contracting with with actual valid sober living facilities, when it comes to reimbursement, when it comes to sustaining our own behavioral health services. And so I just want to bring that up because in Arizona, this is something that we continue to deal with because of these, what they call them, bad actors that really took advantage of our community and our citizens who are at the most vulnerable, right? And now we're not only still grieving the loss of our citizens, but also trying to figure out how do we continue to provide care in a system that isn't, that has become disconnected and has created all of this other red tape that has been difficult for us to provide those services and seek reimbursement through CMS, through the state, that whole channel that goes down. I just wanted to bring that up because that's something that we are dealing with right now in Arizona. Thank you.
Thank you for that. Both to the point about each state is different, but also as a concrete example of ways in which a particular difference has borne out. I want to emphasize that, as many of you know, one of this administration's highest priorities is to go after and eliminate, reduce fraud, waste, and abuse in Medicaid, across the healthcare system. And the intent of that is to ensure that dollars that are available go to the right things and to go to our most needy or most vulnerable citizens and are able to help us provide the care and support that is needed. I think our leadership is very focused on that at the moment for exactly the reasons that you highlight, which is how do we take out the bad actors that are in the program and ensure that we are then redirecting those funds towards the services and the care that is necessary to, in this case, provide the care and healthcare in Indian country and more broadly. So thank you. Thank you for the comments.
So do we have any other questions specifically for CMS Director, Ms. Steffens? Okay, not hearing any, I'm going to move into the general topics. Mr. Bunch, do you want to begin for
a general
today's
welcome?
Comments?
Yeah, for a general welcome, I want to say OCO, Corey Bunch, Dawado. Hello, everyone. My name is Corey Bunch. I want to say Ula Hilisti, welcome. And thank you to the other tribal leaders that are here today. Thank you, Governor, for the wonderful prayer. May we never forget what the Creator does for us. And thank you, HHS staff and departments for being here and taking the time to listen to us today. We want to also thank Secretary Kennedy for his continued support. I believe that he wants what's best for Indian country, and I believe that he expects the best efforts out of all the departments under his administration. As we know, there are over 500 unique tribal nations across this country with varying sizes and varying needs. Tribal nations have existed since time immemorial, and we've faced many adversities. And at one time, we inhabited and occupied every square inch of this continent, and we're still here today. Many of those adversities were brought to us by the U.S. government, and that's why we're here today. Because of the trust and treaty obligations, and because of what the tribes gave up, and because of what the tribes suffered, the federal government is now, at least in part, responsible for the health, education, and general welfare of our tribal citizens. Consultations like this, they must be meaningful. Tribal leaders know what's best for each of their tribal nations, and these programs cannot be one size fits all. It can't also be tribes fighting for a limited amount of resources. So please today, listen to us, answer our questions, and let's use this consultation to help the tribal nations and to also meet your responsibilities. Thank you. Wadon. Thank you, Mr. Chair.
Thank you. Councilwoman Ferry.
Hello, everyone. We would like to thank you for your continued support for Indian health, particularly through the inclusion of advance appropriations for IHS in the fiscal year 27 budget request. We saw just how important IHS advance appropriations were during the most recent government shutdown. Advance appropriations also improve operational efficiency within the IHS by reducing short-term funding actions and the need for emergency contingency planning tied to unpredictable federal spending outcomes. However, the advance appropriation still does not extend to all IHS accounts and line items. This leaves critical programs vulnerable to ongoing uncertainty, including the Indian Health Care Improvement Fund, electronic health record modernization, sanitation facilities construction, and healthcare facilities construction. These are all foundational programs that require stable, predictable funding to effectively serve our tribal communities. Thank you.
Mr. Mattins.
Yes. Thank you very much. In the President's proposed budget for 2028, we request continued appropriations for urban Indian health at $1.64 billion and Indian health professions at $174 million. Continued levels of support for urban Indian health and for the development of qualified health professionals are both crucial to the ability of the United States to improve the health of American Indian and Alaska Native beneficiaries, regardless of where they live. Despite an overall proposed increase in IHS services line items in the 2027 proposed budget by the President, there are proposed cuts to urban health and Indian health professions by 0.4% and 3.3% respectively. These decreases threaten access to health services. Urban Indian organizations operate over 80 facilities in 22 states and serve patients from over 500 federally recognized tribes. Despite performing critical health services with a nationwide impact, they are extremely underfunded. Indian health professions funding supports the recruitment and retention of qualified health professionals in Indian country. Reducing funding to the Indian health professionals line item would undercut the administration's ability to alleviate workforce challenges that the Secretary has committed to addressing during his tenure at HHS.
Mr. Bunch.
Yes, thank you, Mr. Chair. I wanted to comment briefly and show appreciation for advanced appropriations through IHS. That means a tremendous amount to us. It means that when there's a federal government shutdown, like the longest in history this past year, we're still able to provide the critical services to our health services team. Healthcare is one of the most important trust responsibilities that you have, and it's one of the most important things that we deliver as tribal nations, especially at the Cherokee Nation, where we operate one hospital and 10 clinics across our 7,000 square mile reservation. And we serve over 2 million patient visits a year, and we deliver world-class healthcare. And don't take my word for it, though, as Clayton knows. Please come and visit us and watch us in action. We have a dedicated workforce. We employ just nearly 4,000 healthcare employees, and we put an emphasis on Cherokees taking care of Cherokees. With 76% of those 4,000 employees are Cherokee citizens. And I believe the other tribal nations would love to do the same given the opportunities. But we know there's more that needs to be done. And IHS has been quoted as 11% funded overall. 11% doesn't meet the needs of our tribal citizens. For facilities alone, I think there's been $1 billion added this year, but we have at least an $8 billion need for new facilities across Indian country. The Cherokee Nation alone, we've invested recently $1 billion in new healthcare facilities. We also need more money for modernization of technologies and equipment. We need more money for specialty care. We need more money for purchase referred care dollars. I know there's a $57 million increase, and that's to be applauded, but that's not near enough. It doesn't address the needs. I think it's $1 billion in funding overall, but it's estimated to be $13.2 billion at a minimum that's needed for these types of services. The Cherokee Nation, we supplement our purchase referred care dollars by at least $23 million a year. And this only provides for services critical for life and for limb, not all the other services that are needed. Please take into account these critical needs as when you're in talks in future budget discussions. And as, again, I want to mention, we must find a way to provide direct funding to tribal nations and not have those processed through the states. For Cherokee Nation, we must go through the Oklahoma Healthcare Authority, and that is simply not working for us. Thank you, Widow.
Councilmember Cooks.
Yes, Steve Kutz, Tribal Council member with the Cowles Tribe. As we have been talking over the years together with Indian people, we've been working to figure out how we can best take care of the huge historical trauma, amounts of historical trauma we have. And we have people with chronic health conditions that are having difficulty moving forward. And so we have been fighting for more than a decade. And you know, I've been in meetings probably 15 years ago where the Navajo were at the table talking about the importance of traditional healing in our communities. And as we start trying to move these 1115B waivers forward to bring traditional healing opportunities to our healthcare system and the tribes and the people we're treating in our community, we were hoping that CMS aggressively works with the state to help us promote these, and sometimes the tribes may want to talk to you directly because the state is not being very cooperative in these things, and so we're hoping that you work to ensure that we can make these services and these things that we think are going to make such a difference in our community available to our Indian people in our different communities. Thank you.
Chief Harris.
Good morning. Mr. Ingalls, you're up. Thank you for being here. And I have a general statement as far as the 340B program. And with that, again, we welcome you here today, and thank you for being here. And I'm going to make a general statement, and then I'm going to have about 4 asks at the end of that. But I know that 340B program is very heated subject right now. I understand, accept, and appreciate that it's under consultation. But right now, we strongly urge IRSA to exempt tribal entities from any rebate model to be imposed on the 340B drug pricing program. HHS is well aware of the resource challenges faced by tribal health programs that would make a rebate program unworkable, as well as the persistent and disappropriate health issues presented in Indian country that necessitate access to medications included in the program. A 340B rebate model would force tribal entities to pay exponentially higher prices up front for drugs in our communities that our communities rely on, potentially creating cash flow issues that could impact operations. Further, seeking rebates under the proposed model would likely be administratively burdensome for tribal programs, as you should already know, and I'm sure you do, and stress already insufficient workplace capacity. So, at a minimum, a rebate model will stretch already scarce capacity and resources in the Indian healthcare system, and at worst may force tribal pharmacies to close. Let me say that again, may force tribal pharmacies to close. And as the chief of the Catawba Indian Nation, as a USEP representative of 36 federally recognized tribes on the East Coast, we have a lot of small clinics that may be forcibly closed with this. And so, that would create a life or death consequence for our patients that we serve. Therefore, we urge IRSA to exempt tribal entities from the rebate model proposed and ensure we can continue accessing the program in its current form. More specifically, sir, if you want to jot these down or I can email them to you, we would ask, respectfully ask, as you're going through the process and you're hearing comments and all the things that you stated earlier in your opening points, establish a clear and explicit exemption for tribal and native healthcare entities from any restrictions on the 340B pricing, including limitations on the use of contract pharmacies. Number 2, prohibit pharmacy manufacturers from imposing unilateral conditions or restrictions that limit tribal access to 340B discounted medications. So I'll say that again. Prohibit the pharmaceutical companies from putting restrictions and conditions that limit tribal access. Number 3, recognize tribal healthcare providers as a distinct category. Here again, recognize tribal healthcare providers as a distinct category under federal policy, separate from any other safety net entities, with protections aligned to the federal trust responsibilities, as you already know. Number 4, codify these protections through regulation or statute to ensure permanence and prevent administrative reversal. And 5, and the last one, reduce any streamlined administrative and reporting requirements that divert limited tribal resources away from patient care. And so I kind of fumbled through that one, so let me say that one again. Reduce any streamlined administrative and reporting requirements that divert limited tribal resources away from patient care. So, sir, as you know, with your steady tenure in HHS and your positive influence on Indian healthcare, so for many tribal communities, contract pharmacy arrangements are not optional; they are essential, and I'm sure you're aware of that. And so I'll yield to your comments.
Thank you for your comments. As you know, we just ended the public comment period on Monday, and so we're in the process of reviewing those comments. We believe, as of last week, I believe the number of comments that we received was just under 2,000. We knew, though, by going, as we got closer to April 20th, we were probably going to see that number grow exponentially, and it did. From what I understand, I think we're going to be somewhere in the range of about 5,000 comments. I've heard from tribal members across the nation, and they have all said the exact same thing that you just said. I also know it is not the tribal health providers that are driving the problem that we've been trying to identify and what we're trying to correct with the rebate model. One of the things that I want to point out that's going on, from 2023 to 2024, we saw sales under the 340B program increase by $20 billion. As in 24, it was just a little over $80 billion in total sales, but it increased in 1 year $20 billion. HRSA virtually has no regulatory authority over this. We've tried, and courts, time and time again, have stopped us from doing things. And we currently have a number of lawsuits going on that, because of that, I'm limited as what I can say as far as the lawsuits. However, the rebate model was simply trying to put some guardrails in place to try to stop what we knew the pharmaceutical companies could come through with later on. And now we're starting to see this after the rebate model, that the previous rebate model was stopped by the courts at the end. I was on the National Mall on New Year's Eve when I got a call from my staff that said the court just blocked all of it. We were trying to put some guardrails in place on 10 drugs. We knew that there were opportunities that could come through later on that the pharmaceutical companies could put in place. And we started to see that shortly after 2026 started. Eli Lilly was the first one that came through with what they're now doing, what they're requiring. They want to see claims data before they'll pay out in rebates. Now we're understanding that there's others that are starting to follow suit. We have limited action that we can take against that, and we're exploring any opportunities that we might have there. So, Mr. Chairman, I'll get back to you as whatever we can on that. And I did write down your questions, and I do have Cheryl Terrell's here and Alex Rowan's here. They both wrote down those questions. We will get back to you on those. I do want to help and find ways that we can work together. But I also want to figure out ways that we can put some controls on this, because I know what's going on. You know what's going on. Is that some of the entities are using this as a huge money stream. One of the actions that we just lost in court was dealing with what they call child sites. And what a child site is you have a hospital and they open up clinics across the place, and they now can get access to 340B through that. However, the courts now said we're exploring it. We're considering an appeal, from what I understand. The courts have now said you can't regulate those and ask to have those put in their cost reporting reports annually. Before, I've said this before, that when some of these entities were using the 340B as an ATM, now they just back the Brinks truck up to the bank and they're just shoveling money in. And so it's a concern that we have. It's a concern that CMS has, and we're working together to see if there are measures that we can put into place. I hear your concerns, sir. I've written them down. I will get back to you, but we are doing the best that we possibly can right now. But as far as getting to the exemption request that you're asking for, I'm sure that's in the comment period. We're going to have a chance to review those comments and explore all those opportunities.
Yes, sir, and thank you for your comments. But more importantly, the program needs to be systematically linked to our trust and treaty responsibility. Every person that you see, as you know, sitting around this table are leaders of nations, sovereign nations within the nations, and we need to be treated just like the United States wants to be treated respectfully. We need to be afforded the same rights, and we need to be exempt as a nation, not as a group, an entity, or anything else that the government wants to classify us. We are sovereign nations sitting here in front of you, and we want these exemptions, if possible, included in the 340B. Thank you, sir.
Thank you.
Chairman Allen.
Well, I really appreciate this conversation, and I couldn't agree more with Chief Harris on this topic. And thank you, Thomas, for your effort. Without a doubt, the exemptions, exceptions for the tribes on 340B is critical for our success. Now that Mark Cruz is here, I'm going to start over. I'm just kidding. He's celebrating the Blazers won last night, so he's probably up kind of late last night. Joking aside, I do want to raise one issue that I think is important, Clayton, and this is relative to the PRC resources. We definitely appreciate the $46 billion increase that administration is proposing, but and where I think we're in the $1 billion range. I do know, talking to all my colleagues, it's not even close to being enough. I think that our analysis has got to be north of $13 billion. So, we really need to up the ante with regard to PRC. That is critical programs. Chairman Green from Macau made a comment that, when he had a broken thumb, so they said, well, we got some Vicodin then for you. So, that don't work. We have to be able to treat those kind of injuries and illnesses and issues that surface, and PRC money is critical to our success. Thanks.
Thank you, Chairman Allen. I will say Vicodin is quite the improvement from the usual ibuprofen IHS is infamous for.
Vice Chairwoman Grinninger.
Thank you, Chair. My comments are for SAMHSA, so glad to see you here. Is it Acting Director Crocker? Is that how you say your last name?
Yes.
Wonderful.
Yeah, that's correct.
I'm glad the money person is here, so thank you for being here. There are a couple of programs and a couple of questions that I want to highlight just real quick because I know we're coming up to that 10:15 hour here. There are a couple of programs that tribes are very protective over, and we want to see these programs continue to be supported. It's Circles of Care and the Tribal Behavioral Health Programs. And we see that those are looking to be replaced, and that was not with tribal consultation. And we don't know a lot of information about these new programs. And so what is being proposed, and so there are a couple of questions that I do want to read out to you today so that you can either answer them for us here or take them back and get information to us later. But with these two particular programs, we are so protective over them because there's a couple of major issues that they're covering. IHS, while there are great behavioral health programs, they are mostly focused on adults. SAMHSA's programs focus on children, and that is essential for Indian country. I mean, I know that this administration has heard from leaders over the years, we are battling with generational trauma still, and then on top of it, all of our children, whether you're Native or non-Native, are dealing with the pressures and the drugs and the alcohol and the technology of today. The bullying that comes through technology. Like, there's so many other pressures for our kids. And then you add on top of it the tribally centric trauma, right? And so Circles of Care and tribal behavioral health programs really help us meet those needs where there are service gaps that IHS can't cover and where there are service provider gaps. My chairman mentioned earlier, we're paying $350,000 to get a specialist into our new behavioral health facility. And so tribes we don't all have the resources to be able to pay for something like that. So these grants are really essential to us to make sure that our kids aren't dying. And if I had my colleague from Lummi Nation here in Washington State, I know that the chairman there would say, hey, look, and fentanyl at the same time is killing our kids. And we need to be able to meet those needs. One, first, to prevent and heal what's already going on inside of them, and then to respond to when they do step into that world, unfortunately. And that's causing suicide rates to skyrocket amongst our children. It's causing our teenagers suicide rates, death rates, overdose rates. We need to be able to respond to those. And those two programs in particular help tribes to be able to do that. So we really, like I'm saying it again, we feel very protective over those programs, and we want to see them fully supported and funded. And so when we see these new programs, like I believe the title is Behavioral Health and Substance Use Disorder Resource for Native Americans, we don't know anything about that program. So we need to know, like, is that replacing the existing Circles of Care and Tribal Behavioral Health grant? And because one of the other concerns that we have, so here are the two questions. The eligibility of this new program seems to be expanding beyond just tribes, which is a concern for us because that means that the money is going to get diluted, right? If it's getting more money being spread over more people, then we aren't going to be able to meet our needs anymore. So we're seeing that it's expanded beyond tribes, tribal organizations, and then we also saw something here that says including IHS programs. So that caused some confusion. Does that mean so I guess this is a question between you two. Is this new funding intended to supplant what's going on? See, and Clayton's like, I don't know what's going on there. So there's some confusion. We need more information. Tribes need to be consulted about this program. So that's the first question. Second question is the statutory authorization for a new program with it like this. What is it? Did Congress give that authorization already? Or if not, what is that authorization going to look like? So while we appreciate the expansion of these types of programs, we need to make sure that tribal consultation is happening first, and we need to keep these two programs in particular intact. Thank you so much.
Yes, no, absolutely. Thank you for that question. So I would start by saying that the intent is to ensure that before moving forward, that there is consultation. And I'm not here by myself today. Today I'm here with the director and deputy director for SAMHSA's Office of Tribal Affairs, Carrie Herod and Kimberly Beniquez. They're in the audience. And they can reassure and reaffirm what I'm about to say. Basically, so the new program hopefully is intended to provide a little bit more flexibility so that tribal nations, even though the eligibility is going to be a little bit more expanded, the intent is to be able to have tribal nations that do receive the funding are able to sort of frame and decide for themselves what essentially the funding would be used for. So it's not essentially intended to replace the Circle of Care or the Zero Suicide or some of the other programs that have been historically a part of SAMHSA's funding, but essentially to be able to allow that opportunity to, for tribal nations to be able to invest in the way that they see best to fit their needs. In terms of the connection with the IHS, yes, portion, I'm going to say that is absolutely misinformation and miscommunication, and we will respond back. Right, yes, right, with very clear and specific details about that. So we want to eliminate any miscommunication related to that. You didn't bring this point up, but I just want to quickly elaborate on this too. So when you look at the 27 and 28 proposals, TOR, of course, is another program that folks are historically used to, along with the funding that comes through our Substance Use Prevention Treatment Block Grant Program. Those have been eliminated as well. However, the funding actually would be increased in the new program, the resources program. And then the third point to highlight as well is that, I'm sorry, forgot my train of thought on that. Sorry, forgot my train of thought. Actually, I was trying to remember your second question. Do you mind repeating that real quick? Oh, okay, so I've already addressed it. Okay, alrighty. So,
oh, I'm sorry. Nope.
That's
the
what
authorization.
It was. Yes, yes.
Yep.
Okay, so we are actually still in the process of similar to if the behavioral health block grant as well were to go forward, trying to figure out how that would actually be put into place. The authorization for that is not necessarily there at this point, but there's work that's being done to get us to that place. Mm-hmm.
Chair, I know we're at time. Can we bring this back to the lunchtime discussion?
Yes, we will. Okay, so we're at time right now, Governor. I apologize. Will you be here at 11:30? Okay, what we had done earlier today is we knew this group was going to run over, and so we asked the panelists if they had come back at lunchtime. They agreed, and we'll carry this conversation over. And so in the queue right now, we'll follow up with Vice Chairwoman Gringer's comments. We'll go to you, Governor. We have Ms. Yazzie, we have Councilman Dallas, and we have Councilman Steve in that line. And so we'll follow up with that at approximately 11:30. We might have time. Hold tight. Okay, well, we're running late. So we'll see how it rolls, and then we'll do this all over again. That being said, please finish, Ms. Grinner.
Thank you, Chair. And thank you for your responses. So we'll look forward to more information on that. I do want to go back to the concern about diluting the funding. So am I hearing correctly that there is more funding that's going to go to programs like this, even though we're expanding eligibility? Because one of the major themes that tribes bring up every single year is we hate competing with each other. And so I would rather not fight my sister tribes for dollars that are helping keep my kids alive.
Right, right. Yeah, so that line in particular is higher than traditionally. Let's say, for example, tour. Last year, I think it was 65 million. That line in particular would be an 80 million investment. So from that perspective, that particular line would be higher, but when you talk about the circles of care and the zero suicide and the other programs that were a little bit less, the intent or the hope is that the Innovative Behavioral Health Block Grant will be used to continue to support those programs that could possibly be eliminated, but the funding essentially would be still there. It would just probably take a different route.
Okay.
Does that make sense?
I think so. So let me clarify. So this block grant can still support programs like Circles of Care and the Tribal Behavioral Health programs.
Well, that's the intent. So the states, tribes, of course, would have to work through the states, but the intent is for the states and their subrecipients to be able to have more of that flexibility to be able to implement what they feel would address their specific needs.
Okay, great.
Yeah.
Sorry, I'm just want to make sure I'm getting down to the brass tacks of it.
It's okay. I welcome the questions. It's okay.
Yeah, thank
the
you.
Dialogue.
So just wanting to know very clearly that these programs are going to remain supported and how we're shifting things around in the SAMHSA system. And frankly, I think all across the HHS system where programs are being eliminated, but they're being replaced with this and that, it's getting confusing for tribes.
It can be very confusing.
Yeah, and so we're just wanting to make sure that these programs are remaining intact and that the systems that are being created aren't going to cause more barriers or more confusion, and therefore less tribes are going to get access to these monies because they're like, I don't even know what to do next or how to apply for these anymore because everything's changing. The language is changing. The goals are changing, right? So I'm just trying to get some very simple answers and information to know that these programs are going to be protected for tribes.
And I think the answer to that is yes, SAMHSA is absolutely going to do our best to advocate to ensure that that is happening and that is the case. And then also to the point that was made earlier, also to ensure that tribes and tribal nations are a part of the conversation that we will have.
Great, you just answered my last concern, which is where's the consultation part? Because we mentioned it and we didn't have time to go back into it. Okay,
Yes.
so yeah, keeping in touch with the TAC and then keep in touch with tribes through the consultation and listening session process.
Absolutely.
Great, thank you. Thank you, Chair.
Governor, please.
Thank you, Chairman. Thank you all for being here. I'm James Naranjo. I'm the governor of Santa Clara. We're in northern New Mexico. First of all, I want to thank all my brothers and sisters here at the table, and I invite you guys to come to northern New Mexico and see. I come from a small village. There's 8 northern pueblos. There used to be 235 pueblos in New Mexico, and we're down to 19 pueblos. Each governor carries 5 canes to show our sovereignty from the King of Spain, the Mexican government. We have a cane from Abraham Lincoln to show our sovereignty. We also have 2 canes from the state of New Mexico that our people continue to pray for the health and safety and the wellness of our people. In the Santa Fe, the capital of New Mexico, we had a beautiful hospital, urgent care, intensive care hospital, and it dwindled down to a clinic now. In Santa Clara Pueblo, we have a clinic. When I was a young boy, there was 7,000 patients. We're at 30,000 patients in the same building. We try with the neighboring tribes, because we're a very small village. We have less than 2,000 people, 56,000 acres, which is beautiful land that our ancestors fought for. And it's heartbreaking because we continue to work to have a joint venture program to expand However, living in close proximity to the state capitol and to Los Alamos, where we cannot compete with the wages. We talk about this budget for 2028, but yet the PIP production was going from 2035 billions and billions of dollars for national security. And just the other day, they come to our office to expand the PIP production for 50 years. God willing, I hope I can be around for 50 more years. But why is the money being invested so much in national security and not in the health and safety of the trust responsibility that our federal government has for us? You know, trying to retain our doctors, trying to retain our nurses, trying to retain our pharmacists, and in our Pueblo people, we send our children out to get an education with hopes of coming back to provide those services. So when they do come back to provide those services, Los Alamos and Santa Fe County still are employees because we cannot compete. Not only nurses, doctors, and pharmacists, but janitors, teachers, police officers. And so we struggle, just like everybody else here at this table. The trust responsibility, I wish we could be truly sovereign where we didn't have to have a handout from the federal government or the state government, but we're not there yet. And not those small tribes are there yet, but one day we'll be there where we don't have to come to this table and ask for handouts or ask for money. But right now, it's very challenging as a leader. It's very challenging as an individual because I want that health care. I'm a retired lawman that I worked for the state for 25 years fighting crime. And now I'm here trying to fight for my people. The fentanyl crisis, our newborns being born positive, we have no place for treatment. We send our individuals for treatment to come back, to put them right back in the same household again. And so we supplement our budget the best so that we can provide these services because those services are dwindling. And we try to bring these solutions to the table, our comments to the table. But when we're losing to the higher paying counties and the contamination of the laboratories for the chromium plumes, the Superfund sites, the non-Indians with contaminating our Rio Grande, the rivers, and the EPA not doing their job to find the municipalities that we live next to, it's very challenging in all ends. And I wish you would come out and see what we're facing. I talked to Chairman about having this body come to New Mexico for one of our next consultations. And I invite all of you to see how us small pueblos are fighting the fight on all these issues. We're not a big tribe, and the 8 northern pueblos were not very big, but we're very powerful in our language, in our culture, and our ways of life. And so I hope that this consultation can, and in the prayer that I said, can touch the administration in their heart and their mind and to see what they're doing to us people all across the country. As minorities, we just can't pack up and leave like some of the people that come to Los Alamos and Santa Fe. They come and work and they get up and they leave the mess behind. We cannot do that, and we're not going to do that. We fought in our first contact with the Europeans in 1540, and we're still here today. And as I mentioned yesterday, we pray for the unborn. Our ancestors prayed for the unborn. I am one of those unborn. Now it's my job to pray for them so that they have a better quality of life, that they have a better quality of health care, and that they have a better air and water to breathe and to drink. But we certainly need your help, and we certainly need to get with your administration And we implore you to come to New Mexico and see what's really going on in our healthcare system. Thank you. Thank you, Chairman.
Any comments?
Ms. Yazzie?
Good morning, colleagues.
Just a second, Ms. Yazzie. Governor, we all feel your words. I hear you. And we'll remember those words in our future meetings. I want to recognize that. I'll seek for your words. Please, Ms. Yazzie.
Thank you. I echo the words of the governor, and I also want to express the gratitude of all the colleagues here that continue to advocate for all of our tribes, pueblos, and nations. And this point would be to IHS Mr. Clayton Long. I think you've probably heard this broken record, but the Navajo Nation is excited to graduate from the 1993 facility construction list. And so we continue to advocate for the increased funding, and we're really excited, and we hope and pray that the replacement will happen for Gallup Indian Medical Center as it was built in the 1950s. So it's imperative. We do share our hospital with our relatives to the south, the Zuni Nation, our relatives to the east, which is the Pueblo of Acoma and Laguna. And so I really want to reiterate the importance of Gallup Indian Medical Center and the continuance of advanced appropriations, as you've heard our colleagues speak about that. It's important that we maintain the trust and treaty responsibility, and it shouldn't just be advanced appropriation, it's mandatory. It should be right off the top. It's not any different than if any of us rent a home, it's a fixed cost. And I know that I'm speaking to the choir from one tribal member to the next tribal member that's sitting across and now in a federal seat. I just want to reiterate that your advocacy on our behalf on tribes, nations, and pueblos is extremely important, and that you ensure that all of our advanced funding, our advanced appropriations are mandatory, and they shouldn't just be a part of the pot. It's what's owed to us. It's what's truly owed to us, and you know that. And so I just wanted to reiterate the advanced appropriations, mandatory funding, funding for our construction, our facilities. I know Claremont probably wants to graduate from that 93 listing too from Oklahoma. So I think it's imperative that IHS really looks at the listing and maintains that listing and works to get them off the listing. And I speak for Gila River as well, Phoenix Indian Medical Center, and my fellow tribal members from White Mountain Apache too as well, because I know that we are all on that listing. Improve healthcare facilities, it's improve health. We have the ability to keep our loved ones closer to home, and we're not flying them out to Las Vegas and Denver. And I think the most excruciating part is when they are sent out, is they're not brought home. We have to find a way to bring them home. So can you imagine the reduction in costs that will bring to all of us if we have our own facilities in our locations? And I think it really hit us hard during COVID, where we had loved ones pass away in Las Vegas and Tennessee and Texas because they could not stay at our facility. They were airlifted out to various locations. So having our loved ones closer, with all specialty care there located on site, it would probably be the most beneficial thing for the Navajo Nation in our mission of Navajo Healing Navajo. So I just wanted to reiterate that to you, and thank you for being here. Yeah.
Thank you, Director Yazzie. We are very much with you and committed to getting that 93 list finished. The Secretary's pledge for an additional $1 billion over the next 2 fiscal years helps us move forward with that. But as you're all aware, it doesn't scratch the surface on the vast backlog, And then there's the question of, when we finish the 93 list, there is no plethora, there's no limit on the number of facilities across the ITU system that are in need of replacement, and what does that next list look like? Because we've got tribes at the table who weren't here in '93 when we were putting together the first list. And so there's a big direction to figure out completing this task and then planning for the future on how do we address the next. Because we know we want to provide excellent care. We know that regional referral centers save precious PRC funding and keep things in-house and provide a different kind of care. That's as important as any of it. And I think those are serious concerns that we're having. But we're very much with you. It's going to take a partnership between everybody in this room and everybody across the street to make those dreams happen, but we're committed to doing our part and getting that pushed along as far as we can. So,
Councilman Dallas.
Thank you, Chair. I just wanted to thank everybody for their comments here, and sorry for my late attendance. I was over at an event that Mr. Cruz was speaking over here, just about that 93 list over here. There was a group held over with Arizona tribes that are here, 22 tribes. Just hearing some of this thing, they're actually going to the Hill to lobby on a lot of these health issues too. But just wanted to comment on some of the things I've heard so far is that this new program, as you were mentioning, that it's not replacing the circles of care, correct?
Yes. To just also clarify the point, so the funding and investments are still there. I think it's probably just going to look a little different.
Okay. Well, that's good to know. Because it was mentioned that sometimes we are competing with the other sister tribes and things in our states. And the other one was that those of you who don't know that, I guess the secretary had visited our tribe, and we had a new venture. It's a Journey to Recovery facility there that we have there. It's a state-of-the-art. Had the beds there for both the women and men. One of the things that we've seen right now is that there is no adolescent behavioral health care services. And I think that's another component that we're seeing that's really being impacted as the youth. So I just wanted to mention that, because I think for us in our community is like the overall goal is to keep the children, the kids home back in the community. Sometimes they have to send them out to other facilities or things, but they have I think the healing that's there in the community with the traditional things. And so I just wanted to make that mention that, just keep that in mind about the adolescent behavioral health. That's really important. That's for the care services for those young ones. So again, thank you for the time.
Thank you. I'd like to thank Director Steffens for being here today, and I'm glad you were able to field all the questions you did. I also want to thank the panelists for their willingness to come back at a little after 11:30 so we can continue the discussions. We have a couple more in the queue, and then we'd like you to have final comments. All right, that being said, we'll end this panel. We'll jump into the next one. We'd like to welcome Senior Advisor for Addiction Recovery, Catherine Burgum. Sorry, should have told you to launch out there. Victor Joseph, nice meeting you. Okay, welcome, Ms. Burgum. And Burgum, right? Okay, and please go ahead and begin anytime you'd like.
Okay. Well, good morning. It's an honor to be with you all today. Thank you for including me. And important conversations happening today. My comments will be a little bit more focused on addiction and recovery. And I also want to just say hello to Jared from MHA. He's here. Hi, hello. Here. Saw somebody standing over there. Hi, good to see you. Anybody else here from North Dakota? Because that's where I'm from, North Dakota. And so a little bit about myself, and because you're all like, why is she here? What's the whole point of this? So I am a person in long-term recovery from alcohol addiction. I've been in recovery for over 24 years now. Started when I was in high school, blackout drinker from the beginning, drank because I had to get rid of those voices in my head that I couldn't make go away, all the negative talk, and had my first drink, and I thought, all those voices went away, and I thought, this is the answer. This is going to be perfect for me for the rest of my life. And then I had my first blackout when I was in high school, and then that took me on a path of 20-year struggle of all kinds of things that are related to addiction. 8 years pretty consistently of relapsing in the end, and I was suicidal in the end of my drinking. And I didn't have a lot of faith. I was out walking one day, and I just didn't know what else I was going to do. I was trying once again to stay sober after I'd been to treatment centers and a lot of other programs. But I just thought, what could it hurt? And so I just said, I don't know if anyone's out there, but I need help. And I have been sober since I said those words. So that was divine intervention for me because I clearly could not do it myself. And I'm so grateful to have the opportunity to be here today with all of you and doing the work I'm doing. I tell people never give up hope for recovery because from there I ended up somehow as after putting one foot in front of the other and collecting days of sobriety and recovery, I ended up as First Lady of North Dakota, which was never on my radar. Very accidental for me. But my husband came home one day and said, I think I'd like to run for governor. And I was like, no, we have a great life. I was terrified of that. But, there's always a plan, right? Because then what happened was I'd actually been in recovery for 15 years at that point. But, for the 20 years of struggle and the 15 years of recovery, I didn't talk about it because of the shame and stigma. But it was the height of the opioid crisis, and, things happen as they should, and something said, in my brain, you got to talk about it. So I started my first interview with the newspaper. I said, okay, I'm going to talk about I told my husband ahead of time, I'm going to talk about my addiction and recovery. And because I had already announced that my focus was going to be on the stigma, eliminating the stigma of addiction. And he said, why is this topic important to you? And I said, because it's very personal to me because I've been in recovery from alcohol addiction for 15 years. And the weight that got lifted off my shoulder, and the reporter was like, whoa, this is a story, and I was just like, thank you for whoever, my higher power, my person guiding me for putting me in that position because that weight got lifted off my shoulder, that door opened and 1,000 more doors opened. And so for 8 years as First Lady, I focused on eliminating the shame and stigma of addiction. I worked really closely with the five tribes that we shared geography with in North Dakota on a lot of different topics. In a lot of different ways. At MHA, I had a partnership with Dr. Monica Mayer. We worked very closely on a lot of things, Chairman Fox. And my husband and I, we started this thing called Recovery Reinvented, which was a one-day conference focused on eliminating stigma. We had doctors, scientists, people in recovery. It was a very heavy Native American influence and participation. We had drumming, we had dancers, we had people telling their stories, sharing, and Dr. Monica was there for the first event that we had, and she said, and when I first met her, she said that, all the things that are happening in government aren't as important as the fact that we're losing all of our people to addiction. And so right away, she and I connected. But then at that event, we had someone speaking about recovery community organizations. And in North Dakota, MHA was the first one to start a community recovery organization in our state, which is those places are really helpful for people wanting to get support, find people like them, help. Just in a lot of help people find jobs, housing, all those kinds of things. And I remember speaking to the high school at MHA, and a couple of youth came up to me after I spoke, and they said, I don't know what to do about my parents, and I don't know where to go. I don't know who to talk to. And I was able to say, go to the Recovery Community Organization. Those people can help you and support you. Anyway, so back to so the work we did in North Dakota, and my husband also, one of his pillars was tribal relations. And so I have an understanding of how deeply the disease of addiction affects tribes. I have an understanding of that, you and your people are the most adversely affected people across our nation. So I'm grateful for the opportunity to be here today, because part of the work that I did as First Lady led me to where I am today. Two other things I wanted to just mention. I mentor two wonderful, incredible young ladies, one from Turtle Mountain, Chippewa, and the other one from Standing Rock, and they've taught me a lot about culture and how elders view getting help for mental health and addiction and those sorts of things. So it was very insightful for me to have these women in my life. One of the things we did in North Dakota was we really focused on peer support. How many of you have peer support happening in your tribes? Can I just see a show of hands? Okay, because in North Dakota, we're a rural state. A lot of tribes are located in rural locations. We're never going to have all the services we need. So we doubled down on peer support, which are, people in lived recovery, supporting people that are either giving out of the criminal justice system or needing help in some way. And we doubled down on that. And in North Dakota, right now we have over 2,000 peer support specialists. But when I was there, when I left a couple years ago, the majority of those people were Native Americans, bringing the services and support and help back to the tribes. And so that was really impressive. That the people who understood that one of the best ways to help people that struggle with addiction and recovery is just to walk beside them because you've been there. Let's see. So now, what I'm doing today, what led me to where I am today is that I'm here representing the Great American Recovery Initiative, which is a culmination of everything that I've learned along the way. And it's about focusing on the chronic disease of addiction. For 8 years as First Lady, that is what I called it. I didn't call it substance use disorder. I called it a chronic disease because it acts like every other chronic disease. It's a chronic, lifelong, relapsing is a part of it, disease, just like diabetes, just like heart disease. And so when I came here, and my husband does the work that he does as the Department of Interior, I was like, I'll just take a break. I'm not going to do anything. And this thing kept popping up in my brain that it's time. I really needed to do this work. So I'm focusing, I just said, we have to focus on this disease as a chronic disease. It needs to be completely embedded in healthcare. It needs to be treated as with a full continuum of care, just like diabetes, just like like heart disease. So that's what this is all about. It's about that. It's about creating an opportunity for and designing and having the architects and structures, the architects build a model that is a disease model focused on the chronic disease of addiction, and really pivoting away from how we've been treating it, because what happens now isn't working. It continues to be this generational disease that affects people and to no end. And I get it that, some diseases don't have It's hard to see the end, but, addiction doesn't get nearly the amount of philanthropy and funding for research. And, I believe half of that is because it's a disorder, and it's clear, people call it a disorder and not a disease. So having the opportunity to focus on this as a disease is going to be really important. Currently, we get involved when it's addictions at a crisis level. Through treatment, and then we focus on the consequences. And we layer a lot of programs and things on that, and we need to get involved much earlier. We need to talk about these things at early doctor's appointments and prevention. So we're not just someone comes to an ER in an overdose situation. They're given Narcan right now, and then once they're doing better, then they're released, or they're able to leave and go out, and then sometimes they come back 2 hours later having overdosed again. In my view, what happens is, if someone comes for an overdose to an ER or some hospital or healthcare facility, they're moved into the facility. They're not, they're offered an opportunity for detox. They're offered an opportunity for care versus just being, so it's more of that kind of model. So anyway, so that's part of what the Great American Recovery is about, the disease model, the chronic disease model, and then also just filling in the gaps of what can we do to make things better for the situation that's happening now. There's just way too many gaps. People fall through the cracks. So that's what we're looking at also. And so the opportunity to partner with you and, in any way would be very much welcomed. And so I'm here. I'm grateful for the opportunity to talk to you about what we're doing. Having the opportunity to focus on the disease model, focusing on the gaps, and then also looking at what's working out there. What are the best practices? Like, how can we lift up those best practices and as examples of what's working in different communities and different places across the nation is also what we'll be focusing on. So anyway, that's pretty much what I have to say. It was like I didn't even know I was going to do this morning, and then I was like, this is definitely going to be the best part of my day. So thank you so much for the opportunity, and I'll look forward to hopefully connecting with you all in the future and soon. And thank you, Mark, for all the work that you're doing as well. Really appreciate that. And I know that Secretary Kennedy is very focused on the work happening out there. I know he's been doing a lot of visits out there in tribal communities, and so I look forward to the opportunity to work with him as well in that endeavor. So thank you so much.
Thank you. We want to thank you for coming here and presenting this initiative. Thank you, and we look forward to working with you.
Thank you. So we don't have an opportunity to, okay.
This was just an introduction, and so. So moving right into our next panel, we want to invite Director Klein, Chief Medical Officer Fudu, and Dr. J.
Start off by saying his last name.
My cousins think I don't know how to pronounce my own last name, so it's hopeless.
Okay, why don't we go ahead and get started? We're running a little bit behind, and we want to thank you for your patience. We'll probably run over the allotted time, and then we'll go ahead and move forward. So what I'd ask is brief comments. We have a lot of tribal leaders that would like to talk with you. And so with that, we'll start. Whoever wants to start, we can go move forward.
Okay, so I'm going to speak on behalf of both the NIH and the CDC in one set of comments. So good morning, tribal leaders, representatives, colleagues, and I should say also friends, since I've got to know some of you over the course of the last year. Thank you for being here and sharing your expertise and guidance. Before I want to begin, I want to acknowledge I do have two hats, hopefully not forever, the NIH hat and the CDC hat, and I'll try to keep them separate and leave it open for you all to get questions on both. I'll begin with a brief overview of NIH activities, followed by a short update by the CDC. So at the NIH, the investment in health science and research is central to the NIH mission, and we've heard clearly from you that it's central to the health and future of your communities. As the largest funder of biomedical research in the world, the NIH has a particular responsibility to invest in the health of Native American and Alaskan Native communities, especially given the real health needs of those communities. There's the highest burden of chronic disease in the country, maternal mortality, substance abuse, cancer, a whole host of other problems that you all know about all too well. Addressing these problems requires sustained, targeted, community-driven investment and I should say collaboration, like deep collaboration and listening from the communities where we are partnering with you rather than telling you how to do research so that you can drive the research needs of your community. To ensure this, the NIH established the Tribal Health Research Office within the Office of the Director, which is the central coordinating company. You all know, I'm sure, Corina Walters, who's in the audience somewhere. There she is. She's waving. She's been absolutely central to my learning about these policies and these issues, and I'm really grateful to her for that, as well as to all of you that I've had the chance to get to talk with over the last year. Let me just highlight a few programs, and then I'll put on the CDC hat. First, we have the Native American Research Center for Health, or NARCH. It's one of the most significant, long-standing investments on tribal-led research. And since 2000, we've directly funded tribes and tribal organizations to lead their own research agendas. And I've seen with some degree of happiness that there's been real developments in training investments so that the Native American communities can have folks from your communities who know your communities well, trained to do research, be successful in getting funding from the NIH. One example, the Fort Belknap Indian community, in partnership with Johns Hopkins, is using their award to build tribal data systems for public health decision making. I can go on, but I want to leave time for you all to ask me questions. Second, the Tribal IRB Establishment Enhancement Program. This program supports tribes in building and strengthening their own institutional review boards. This is really important because there's so many of the problems in research have come from our not understanding the needs of your communities regarding biospecimens and a whole host of other things. Having your own institutional review boards, I mean, that's just the right way to go. That helps solve that problem. The third, the Tribal Undergraduate to Graduate Research Training and Leadership Experience, or we have great acronyms to the NIH. It's called TURTLE. The idea is to invest in young people in your communities who are excellent at science and make sure that they have the resources they need to become the next generation of scientists. In March 2026, NIGMS made its first Turtle Award to the Wabanaki Public Health and Wellness program in Bangor, Maine, in collaboration with Washington State University. There will be many, many more to come. Fourth, the Native Collective Research Effort to Enhance Wellness, or NCREW. It's a major multi-year NIH investment focused on overdose, substance abuse, pain, and mental health. It directly funds tribes and Native serving organizations. Phase 1's underway. Phase 2 opportunities are now open to all eligible tribe and Native serving organizations, with applications due on July 31st. It's a huge opportunity for broader participation for tribes and Native organizations that have not previously participated in NCREW. And then finally, IRINA, the Intervention Research to Improve Native American Health. It's a NIH-wide program for culturally grounded intervention across a range of health priorities. Applications are due October 21st of this year. There's a whole bunch more, but I don't want to take up so much of my time, and I still have the CDC hat. So if you forgive me, let me put the CDC hat on for 2 seconds, and then I'll stop talking. Okay, so NIH, not CDC. Okay, at the CDC. You should, before I start talking about the CDC, I've been there for 2 months, and unlike the NIH, where I've learned a lot about the NIH investments, I'm still learning about the CDC. So it's not, if you could forgive me if I have questions, there's folks in the audience. I've brought over Corinna Walters to serve as 50% detail at the CDC while I'm there to help. I've learned a ton from Damien Kilsback, who's at the, there's Damien over there in the audience at OTASA and at the CDC. So it's, so if I don't know something, there's folks in the audience who work closely with me that do. At CDC, we recognize and respect tribal sovereignty without interference and the importance of our government-to-government relationship. We remain committed to consultation that is consistent, meaningful, and grounded in respect. We also recognize that the federal government's trust and treaty obligations to Indian health and public health. We take these responsibilities seriously to reflect those obligations in how we design, fund, and implement our work. At least that's the aspiration. At the CDC, we continue to recognize tribal nations as public health authorities, and I should say personally, in the time I've been there, I'm absolutely committed to this. I want to strengthen tribal access to CDC data systems, modernize public health data infrastructure for tribes, and ensure that tribes help shape the ongoing data modernization efforts from the start, not after decisions are made, right, to include you all in our decision making. We continue to improve how CDC funding supports tribal leadership. I know there's lots of questions that folks will have about that. That's something I'm very aware of and I'm working on. And where statutory authority allows, we're expanding direct funding to tribes. Where limits exist, we're working to be transparent about them and build greater flexibility into funding announcements, cooperative agreements, and reporting requirements. Because the goal is simple: the CDC funding should support tribal health, public health leadership, not constrain it. Okay, I'm going to stop. There's a bit more, but I want to leave time for you all to ask me questions.
Mr. Quinn. Yeah, thank you, and thank you for having me. I'm new to tribal affairs. I haven't been to one of these, so I'm really here to also to listen and learn. So I'm representing the Agency for Healthcare Research and Quality, where I'm the director. And so you heard from Dr. Bhattacharya, and on one of his hats, he's at NIH, he's developing cures. His other hat at CDC, he's looking at population health. FDA is focusing on food and drug safety, and AHRQ is actually the only government agency, the Agency for Healthcare Quality and Research, that focuses on health services research. And so we're really looking at healthcare delivery. We're making sure that that quality healthcare is available and accessible to everybody, and that things are done right. Basically, we have 3 areas of core competencies. The first of which is important to the tribal communities is the data and analytics portion. So we have over 30 years of experience in building core national health data resources. We have a flagship data source, the medical expenditure panel surveys. It's the only national source measuring how Americans use and pay for medical care, health insurance, and out-of-pocket spending. Of particular interest, I think, here is our healthcare cost and utilization project. I think Pam Owens, the director, is here. This contains the largest collection of longitudinal hospital care data in the United States. It covers inpatient stays, emergency department visits, and ambulatory surgery encounters. And where Pam is actually working together with you on developing the data metrics and data projects within the tribal communities and the tribal hospitals. So this is particularly important for you. We have what's something called the Health consumer assessment of healthcare providers and systems surveys, CAPS, known as CAPS, which ask patients about their experiences with healthcare in various outpatient, inpatient settings. And that's actually used throughout the country as to measure patient metrics. And then we have a network of patient safety databases. We use patient safety data to create dashboards, chart books, and topic spotlights for national learning. So this isn't all of the data that we do, but it's reflective, I think, of sort of the range of activities in which we're engaged. The other area in which another area in which ARC works is evidence-based research, and basically what we're trying to do is show what works and what doesn't, what healthcare and what preventative strategies are helpful and which things are not. We then disseminate that information to the frontline healthcare providers. We create materials that teach and train physicians and other healthcare providers, and we continually look for ways to apply evidence to improve best practices in patient care. So this is another area in which I think we can work very closely with you all and with IHS. Finally, we look at patient safety. We invest in research that allows us to understand areas in which health services may fall short, how to make care safer, we use evidence-based strategies to improve the quality of care and produce, again, materials to teach physicians, providers, hospitals, and health systems how to implement this knowledge into practice to improve patient outcomes. So what are we doing for the tribal communities? First, as I had mentioned with our HCUP project, we're developing pilot sovereign tribal data projects that provide the tribes with their health data. So it's their health data, but we're helping organize and present it. We're helping to develop a plan and initiate a pilot data project that will empower Native communities with actionable, accurate health system data and analytics. We already do this for the states, and our goal is to provide this unique services to the tribes. We're developing and initiating a plan for a survey to capture information about healthcare access, coverage, and spending in tribal communities and in urban populations. So that's what we're doing on the data front, and those are our most immediate projects. We're in the process of establishing a tribal advisory committee. We're going to participate in several site visits this year. We're trying to better understand the needs and priorities of tribal nations. We're going to visit tribal facilities, looking at various healthcare approaches. And these will help us connect and actually gain an understanding of where we might work together, and will help us identify existing research and other gaps that in data and evidence that we can perhaps help fill. We're working also on toolkits. We have some toolkits that we've put together, and I met with Dr. Kanan about one of them. And we talked about modifying them potentially for appropriateness within your communities. So we could take products that we have, and I say products sort of loosely. They're government productions that we're providing as a service, but we're going to work with the communities, the tribal communities, to help make those appropriate for your settings. Just as an example, since we talked about data, an example of some of the HCUP data, I'll give you some facts. And they put together, Carmela Roybal was instrumental. She's terrific and has helped us, but put together with Pam Owens some opioid data, and I'll just give you some numbers so that this shows you the kind of data that we can help with. Between 2018 and 2023, the number of opioid-related ED visits and inpatient stays has increased among American Indian and Alaska Native persons, 90% and 46% respectively. So we track those ED visits and inpatient stays. We actually were an early finder of signals through our ED visit analyses of the opioid crisis itself. In 2023, we documented 22,993 ED visits related to opioid use. And between 2018 and 2023, the population rate of ED visits and inpatient stays related to opiate use disorder increased among American Indians and Alaska Native persons aged 18 to 64, 86% and 36% respectively. And this is at a time when the population rate among non-American Indians and Alaska Natives declined 13% and 15% respectively. So this is how we can help you, and we are working already to help you in the data realm. Look at your own data and help identify gaps and target areas on which we can help you improve your health, and we're pleased to do so. When I first came on, I learned very early that the tribal nations were a high priority of Secretary Kennedy, and we're really excited and enthusiastic about the opportunities to work with you and to better health care for all of your constituencies.
Right, I'll go last. Thank everyone for having us. My name is Rafid Fadul. I'm the Chief Medical Officer and Acting Deputy Director at ARPA-H, which is the Agency for Advanced Research Projects in Healthcare. We're very grateful to be here. We appreciate all the tribal nations' representation here and the elders. And we're here really both to share some of the work that we're doing and also to listen. This is my first time at this event, and so both are priorities for us. ARPA-H, we're the newest agency within HHS. We were established in 2022 to really accelerate better health outcomes for everyone by solving very specific hard healthcare problems that the broader ecosystem in healthcare can't do for whatever reason. We are not a grants agency. Just as important as what we are not, and we are not driven by grants. We use a different funding mechanism called an OTA, which is really milestone based, and that gives us the flexibility to double down on those efforts that are working, and also pull back money and redirect it if the efforts are not. We're here today really because we believe that these healthcare innovations that we build must reach everyone, including the tribal nations. And that means actually designing with those communities, your communities, from the start and not as an afterthought after the fact. We're a funding agency, and we fund teams to build solutions with these communities. And so it really is a partnership as we view it. We exist to close this gap that is between what medicine can do and what patients actually experience. And that gap is actually wider in Indian country than most anywhere else in this nation. And we're here to listen, to share what we're building, and to find ways to build together. And I'll give you a couple examples of some of the programs that we've launched with great success in partnership with the tribal nations. One of them was, you may have recently heard about it in the news. It's called NITRO, Novel Innovations for Tissue Generation and Osteoarthritis. Essentially, this is the goal of this is to eradicate osteoarthritis. NITRO was actually the first program that ARPA-H kicked off. It was launched with one question: what if we could make joints heal themselves? And we kicked off actually at the Cherokee Nation in Oklahoma in March of 2024. That was the first ARPA-H funded program to launch on a tribal nation soil. And we're very proud of that fact. Phase one there has been really promising. We're showing early signs of regeneration, and that's actually what the recent news was about. This month, to that end, a Dear Tribal letter actually just went out inviting participation in a clinical tribal network. Our trial network for the tribal nations. If realized, this would actually support clinical trial sites on tribal land with buy-in from tribal leadership, making cutting-edge nitrotherapeutics directly accessible to tribal members. That letter has the support of HHS and IHS leadership. I encourage you, if you know anyone who is a recipient of these letters, please encourage them to respond. We want this participation from the tribal nations, and we're humbled and really excited by the great initial response we already received from it. And so Dr. Ulrich, who is the program manager and the advocate for this program within RPH, he's very excited to engage with Tribal Nation. So if you have not reached out, I encourage you to do so. Another program that we've launched is something called Paradigm, which is a platform for accelerating rural access to distributed and integrated medical care. Essentially, what we have done is put a hospital in a van, right? In very simple terms, the great problem that we all know is that where we live is actually not close to the points of care of access, and it's an unacceptable fact that your zip code or where you live determines whether you live or die. We can't accept that in this day and age. And so if we can't go to the mountain, we will bring the mountain to you. And that's what Paradigm does. It was designed for tribal nations and rural communities. IHS provided input from the very beginning on program design. The core of the idea was essentially that we bring hospital-level capabilities to the patients where they are. Carmela gave me a staggering fact earlier today that 80% of patients who are diagnosed with cancer in the tribal nations don't receive care for it. Unacceptable, absolutely unacceptable. We have to provide all the options that we can. Another point about this program that I'm really proud about is that some of the performers are actually engaged with the Alaska Native Tribal Health Consortium, Utah Tribal Leadership, Indian Health Advisory Boards, and the Navajo Center Work Group. So again, we need to understand the community needs so that we can build appropriately. And that happens by integrating with our tribal nations, with these communities on day one, right? It can't be an afterthought. Another program that we had launched was MOX, or Making Obstetric Care Smart. And so, when we look at the data, American Indian and Alaska Native communities face the highest maternal infant mortality rates in the country, 54.6% higher than anywhere else in the nation, according to a recent study in 2024. Again, unacceptable, not for our children, right? So MOX endeavors to replace that 50-year-old technology, this subjective fetal monitoring, with data-driven tools that can actually predict the risk of a complicated delivery and detect fetal hypoxia in real time, and then recommend the next best intervention. The program manager, Dr. Kate Arnold, who was working on this one, she's met with IHS representatives, and even an IHS team member was actually serving as a proposal reviewer within the program, and another was invited to actually be a Proposer Day representative and participate in a panel there, again, helping guide this program. So how does RPH work with the tribal nations, and what are our commitments? Again, we're a funding agency. We fund the teams to build the breakthroughs that will lead to the health solutions. We work with the tribal nations for better health outcomes for everybody. We coordinate all across HHS. Paradigm is a multi-agency engagement that includes IHS, CDC, ARC, HRSA, FDA, CMS. We are not working in isolation, and we can't. The moment demands that we all work together. And we're committed to maintaining these ongoing relationships, and this is not lip service. It's not a one-time consultation. We heard very clearly from tribal leaders in our 2024 listening session that you want direct partnerships, not intermediaries. And RPH is built for that. Our programs are designed so that communities most affected by a health problem are the ones shaping the solution. And this is not a talking point. This is just how we operate. When we think about what we do with our partners, everyone plays a distinct role here up on the panel. NIH, CDC, ARC, and RPH. It's distinct but complementary in the work we can do in supporting tribal nations. NIH really builds the foundational knowledge base, and RPH takes that knowledge and compresses the timeline from discovery to deployment. CDC, I'm still going to look at Jay because he wears both hats still, provides the surveillance and prevention infrastructure. And we build those breakthrough tools like the Paradigm's mobile platforms, MOX fetal monitors that can be deployed through that infrastructure. And then ARC is working in healthcare delivery, looking at quality. We were going to build the tools that help with effectiveness and scalability in real-world settings, particularly in tribal health settings. So together across the table, we can actually represent a continuum from knowledge to capability to deployments, and the tribal nations have a seat at every point along that continuum. So again, I want to just commit on behalf of RPH and all of us to what we believe is a very strong relationship, not as a one-time engagement, but as an ongoing partnership. There are multiple pathways for involvement, and I encourage you to explore them all. Tribal nations can be performers. You can send us a program manager. You can participate as an ARPANET spoke, which is our community hub and spoke model. You can participate in the clinical trial network designs, or simply just subscribe to our newsletter so we can know what's going on and you can actually get the upside of all the work that we're doing. In closing, I just want to say that the health challenges that face the tribal nations are not new. And we are building the tools, though, the regenerative therapies, the mobile hospitals, smarter maternal care. These are new, and they were designed from the start to reach the communities that need them most. And so we're here to listen, and we're here to partner, and I'm very grateful for the time. Thank you very much.
Thank you. And we're going to, as we go through this process, our tribal leaders are going to give their comments and questions. We'll ask you all to hold off on the answers to the end. And so with that, we'll go with Vice Chairwoman Williams, please.
Good morning. Thank you for all your comments. My name is Krista Williams. I'm the Vice Chair for Coshada Tribe and also serve as Treasurer for United South and Eastern Tribes. I just wanted to say we were encouraged by the language in the fiscal year 2026 Labor, Health, and Human Services, Education, and Related Agencies Appropriations Act that created a new 3% set aside of the total public health infrastructure for tribal nations and tribal organizations. However, tribal entities have not received much information regarding the set aside and how it will be operated. Can CDC provide more information on this 3% set aside, including what it will be used for, what entities will be eligible to apply for the funding, and how CDC will ensure that the set aside is not inappropriately distributed to non-tribal entities? And does CDC intend to conduct tribal consultation on this set aside? We also remind HHS of its obligations to ensure tribal access to HHS data in our capacities as public health authorities, as well as the importance of ensuring tribal data sovereignty. HHS now has internal policies intended to govern data sharing with tribal nations and TECs, and must remain committed to facilitating timely and efficient data sharing with tribal nations and TECs in accordance with statutory requirements. Tribal nations and TECs require access to usable quality data in order to protect and serve our communities. In addition, HHS must prioritize protecting tribal data sovereignty in all research and programs across the agency. Also, the NIH Tribal Health Research Office has been leading efforts to develop a comprehensive policy applicable to NIH research programs that recognize indigenous data sovereignty. According to the website, the NIH Indigenous Data Sovereignty Policy aims to uphold tribal sovereignty regarding the collection, ownership, stewardship, access, transfer, and use and reuse of data. Tribal data sovereignty continues to be a growing priority for tribal nations. So can NIH provide an update process to develop this policy? And when will tribal nations have the opportunity to consult with NIH on a tribal data sovereignty policy? Thank you.
Chairman Allen.
Well, Ms. Williams put out some good ask. I'm looking forward to the answers. But I'm going to give my best shot at Director Bhattacharya. How close am I? Close enough for the government work?
That was fantastic.
Close enough for the Fed. Okay. You got a tongue twister. You could be a member of Hopi tribe. Anybody seen the members of the Hopi tribe? You can't pronounce their names either. Anyhow, I just want to say thank you. And Crystal definitely raised a lot of our issues with regard to tribal sovereignty. And you know, Roger, you raised some projects regarding data and metrics with regard to Indian country, and that's where our engagement with you, is important, because what metrics are you using? Does it make sense? And so I'm hopeful that that the tribal advisory for NIH is being consulted. They typically are experts, in the world of data collection and gathering that is critically important for the tribes as we're trying to get an assessment of how well we're doing. What is the status of Indian country, and how well do we respond to different kinds of challenges. I don't care whether it's COVID, measles, whatever the issues are out there, how are we doing, and how well are we performing in terms of providing quality health care? What are the metrics that we're using, and how well do we perform? So I was asked to put in a plug. I want to make sure I get this right, and if I don't, we'll follow up. But we could use a quality data analysis on our tribal epicenters. Can get data from the current procedural terminology and the healthcare common procedure coding systems that are standardized systems, and they're used for medical billing and insurance reimbursements, with CPT level 1 and HCPTC. God, that's an acronym. Level 2, which deals with the products, supplies, and services, et cetera. So there's lots of data that we do need, and so one of the things that we get concerned about is what data are you gathering, what kind of information are you gathering that can be helpful for us as we move our agenda forward, and we push hard for more resources from all of HHS, including NIH and all the different programs within NIH. It's always a heavy lift. People like me, I'm a tribal chairman, I got a lot on my plate. Your world is way outside my wheelhouse. But the people that work for us, just like state governments, et cetera, they have to be able to gather this so that we know that we're gathering data that's going to be of value. We are sensitive to it, like Crystal said, in terms of how this data is used. Often data can be used against us, and we get very defensive about that. And that's why we raise the issue of tribal sovereignty regarding data so that it reflects the true story of what's going on in Indian country. And that for us to be working with your agency is critically important to our future success of our operation. All day today we've been talking about budget issues. But, this is the budget issue in terms of, is there set-asides, or are you working closely with tribal epicenters, with regard to, are they funded correctly, or are they underfunded, which is a typical case for most of our epicenters. But the Indian colleges that have research as well, and we want, as you talk about trying to recruit Indian scientists and analysts. It's a unique sector that we don't normally, our students don't normally gravitate to this world. And we have a high interest in trying to encourage them to be of concern and the motivation to be interested in this expertise, because we need it, quite frankly, and so that we're having somebody who, from our backyards, if you will, be engaged with agencies like yours moving this agenda forward. So I'll leave it at that. If I wasn't clear about the ask, I know that there's things we want to do that you're trying to do to help make a difference, and we appreciate that. But we want to make sure that you're doing it in a way that is a collaborative level that creates a comfort level for us in Indian country. Thank you.
Steve, please, Councilman.
I'm a little bit, Steve Kutz, tribal council member with the Couch Tribe in Washington State, representing the Portland area. Also sit on the CTAC with Herminia over here. So welcome. We're CDC stealing you away from us, huh? Okay. Well, so of my more than 50 years in healthcare, 25 of that was in public health. And so I'm interested in the tribal set aside for public health because so I know that the Cherokee and probably some of the other big, huge tribes have a very comprehensive public health system. But IHS did not set out to set up public health. You know, taking care of healthcare was not public health. It was not their mission. And so many tribes do not have much of a public health system, if at all of a public health system. And so we have been constantly asking the CDC, because there's a lot of set-asides and money that's sent down to the state that's public health money that's sent down to the states that doesn't make it out to tribes always. And so we're interested in looking at how we can increase the public health stature in tribal country. Then I think I had one other thing that I wanted to talk about was there was an ask in here from some of the tribes around improving Native health care, cancer outcomes, and there's some concern that they have about the elimination of the National Institute on Minority Health and Health Disparities, which houses the Initiative for Improving Native American Cancer Outcomes. And so they have some requests, and they're wanting to know how we can better support the administration and Congress supporting your NIH's goal of improving Native American health care outcomes, and how do we get initiative funding commensurate with the 2026 levels. Cancer in Indian country is a huge issue in many areas, many of them because of the places where their reservations are and some of the things that happen, but we need to better understand why we're having these issues, and we want NIH to improve the Native American Cancer Outcomes Initiative to address the specific contexts that impact cancer outcomes in our American and Alaska Native communities. And so we're asking for more of an initiative in looking at that in Indian country. So thank you.
Councilwoman Cobb? Huh?
Stephanie Thompson.
Oh, okay.
Sorry about that.
Thompson.
My name is Stephanie Thompson. I'm a councilwoman for the Lac du Flambeau Band of Lake Superior, Chippewa. I'm also an EMT, and so I wanted to speak on that a little bit today. In our town, we're a checkerboard reservation, so we have a town of Lac du Flambeau, and we have our tribe, our reservation of Lac du Flambeau. I served as a volunteer on our town's EMS department. And in the time that I was there, it became very apparent that for many decades we've been lacking care. We've been lacking support, and that there's some issues on the department that have been decades long and ongoing. My tribal vice president can speak to that as well, as he served on that same department for many, many years. And so I want to kind of alert you a little bit to something that we have going on there, that we have response rate times that on a good day are about 30 minutes from the time you call 911 until somebody arrives. I've had times where I'm actively doing CPR. I had to go direct to scene because I couldn't find a second person to attend with me, so I went direct to scene in my own personal vehicle, assisted with law enforcement, doing CPR, and that CPR had lasted 50 minutes before ALS arrived. The outcomes are discouraging. The response rate times are discouraging. There are times when a call will come out and the next nearest township that covers ALS for us, they're already on a different call, so now we're waiting for somebody that is a 45-minute drive on a good day to come and assist us. So my ask is that we need quality data support. on paper, it looks like we're served. We have an EMS system in place, but the numbers don't match. So I'm asking for support in expanding healthcare access, especially with EMS, into rural communities, into rural clinics. I recognize that I have a great group of people here. I was listening to all of the different things that you guys are excited to speak about and motivated to speak about, and that made me really excited and thinking that there could be potentially something done here, because I know that ambulance deserts exist. I know that, over 73% of ambulances are in rural communities, and that's not just for tribal nations, that's across the board. We have inadequate EMS coverage in our tribal community, and we are technically served, but we're functionally underserved. My request that there's funding and prioritization for quality data to look at EMS access disparities, specifically where there's jurisdictional overlap. I would also like to see some of those outcomes or some of the research on the cardiac survival rates in our rural communities, the trauma mortality rates, the stroke response times, overdose response times. As you know, when it comes to those situations, minutes are critical. When we have a stroke patient that is presenting and it's an hour before they are able to receive higher level care, those are impacting my people, those are impacting my community, and that's not just tribal people. So I'm asking that you would help fix the gaps in these tribal areas, and that you treat this as a safety issue, not just as an infrastructure issue. As I said, on paper, it looks like we are served. When we go after and we look for different funding sources, a lot of times we're ineligible because they say you already have coverage. It's coverage for a reservation that is ran by a different government entity, and it's not ran well. So I would request that we need help with NIH to help quantify those gaps so we can really make a strong point and go after those things and help serve our people, because, the lack of care is killing our people. And I know that doing a pilot program like that could be replicated across Indian country. I know from listening to the testimony of our sister tribes here, a lot of them are facing these same health disparities. And then I would also ask that the HHS update their website. When I went to go and take a look at some of the tribal affair dates, and that it hasn't been updated since 2023. So that communication piece and being able to understand the full picture of what's going on could be honed in a bit more. Thank you.
And once again, my apologies for getting your name wrong this time. So with that, Councilwoman Freyes.
Thank you, and thank you to the panelists. Dr. Bhattacharya, it's good to see you again. A little bit about myself. I'm tribal council for Pasquayaqui tribe in Arizona, and I also co-chair NIH TAC, and I sit on the TAC for CDC, and I just recently got appointed to the STAC, so I keep myself busy. And I'm also a science junkie. So I got my undergrad degree in biochemistry and my master's degree in public health. And for me, as a tribal leader, I'm able to use the knowledge that I've gained through a public health lens and science. And public health is science. And really to see how do we build community? How do we rebuild the health of our community? And it's looking at it through the framework of the social determinants of health, where we live, where we work, where we play, and where we pray. And what is it that we need to do in our community to improve that? And so science is so important. There's so many questions that we have about what's going on in our community and why things are happening in community and what type of interventions should we be creating science-based intervention and intervention that is based both on empirical data and also, other data. It's really important for us to really look at community and build that up. I was, quite frankly, I was a little disappointed that the panelists right before you didn't stick around, because the topic that was brought up with this new initiative is really important for us in Indian country. And I wanted to share that, addiction is a crisis for us. It is an epidemic within our communities. And what's happening with the opioid epidemic and how it's now the fentanyl epidemic, it's killing us. And most recently, we had the opportunity as a co-chair for NIH TAC, I had the opportunity to meet with Dr. Volkov from the National Institute of Drug Addiction and also the Throw Office to come out and talk to, at first it was going to be with myself, but I decided to extend that invitation to all of the tribes in Arizona and to have a roundtable discussion about addiction and the impact that addiction has in our community. And one of the things that I shared was, and inviting, tribal leaders, behavioral health providers, and anyone you think that should be at that table. And because I've learned a lot in our community about the impact of opiates and fentanyl. And one of the things that I learned from the office of our prosecutor was the big difference that fentanyl is having in our community, not only with death, but also with brain chemistry. With the fact that a lot of the people that have gone through our court system and are deferred over to our wellness court are not successful. Whereas other addictions, they've been very successful in our wellness court, but when it comes to people that are addicted to fentanyl, the wellness courts are having a lot of challenges. And that for me is a question, right? It's a research question. What is the difference? What is happening to our brain chemistry that the fentanyl is literally frying our brains? That it's very hard for them to recover. And for me, it makes me think about what needs to be done. What other interventions are there? What do we not know and understand that we should better understand to help our community? And I just want to, that's just an example, because I bring that up because I work very closely with Throw Office, and I appreciate everything that Throw does, but, and what you're doing now, doing double duty. There is such a need to increase the budget for the Tribal Research Office. It is around approximately $3 million. It needs to be at least doubled. There's great work that's happening around data sovereignty. There's great work that's happening around historical trauma. There's work that's happening around creating policies with our I talked about data governance, but also with working with urban Indian health clinics and research and creating policies that the tribes have a say when it comes to urban Indian research. And there's no go-around. Even international research. There's so much that needs to be done, but the office is, they still are missing a couple of people, key people, the deputy director and other folks that haven't been reinstated. And there's just a lot of work that we have brought up as TAC members to the Throw Office, things that we'd like to do that connects directly to their strategic plan. But they need the staff. So as this budget consultation, I'm advocating to double the budget of the Throw Office so that they can do more and they can do what the STAC has been asking for when it comes to research, when it comes to public health, when it comes to all of these different things that you hear here, because it's so important. And also, I just want to say that there is a huge need for us to continue to support our Indigenous scholars, our tribal scholars, working with these usually university institutions, higher education places. Is a lot of times in these institutions is our Native scholars don't even have an opportunity to do the research that's important to us because they're blocked. because the professors they don't understand the research. And even to a certain point, NIH may not understand the research, may not feel like it's relevant, but it is relevant. And so there needs to be that understanding even at the graduate level when our students are trying to get work that we say, yeah, that's important, how do we get it done? And it's shot down by the institution. And we need to do more to support our tribal scholars so that they can do the work that's relevant and important to tribal nations. Thank you.
So earlier, before, we have 2 more in the queue, and we can get through them. And one of the things that we talked about, we started late, and I asked if you guys would be okay. I'm still asking, are you okay with time? Okay, and so if that's the case,
Can I be added to the queue?
we're going to run a little bit late here. And so I have 2 in the queue, and we still need to go back to the last one. And I'll get that all figured out. So with that being said, I have 3 in the queue right now. I'm going to go with Chairman Linkwit, then Vice Chair Hartford, and then Vice Chair Grenford. Okay, and then we'll call that, and then you all be able to respond to the questions and stuff. Please.
Thank you, Chairman, and thank you so much for being present and sharing this space with us this morning and trying to come up with some solutions, for a lot of the issues. I keep hearing a phrase over and over: quality health care. Quality health care. I heard it yesterday, today. I'm going to hear it tomorrow too. But quality health care cannot exist without quality data, complete data. I want to ask a favor of you. When you get a chance, pull up the Crow Creek Sioux Reservation. Look at childhood obesity, look at childhood diabetes, whatever. Pull something up and look at it. You asked us as tribal leaders to look at the gaps in our data. When I pull data on Crow Creek, all I see is gaps. There's at least 4 different entities out there collecting data on my people: federal government, state government, tribal government, and also private entities. Neither one of them are talking. So when we go to look for resources, funding, look for help for some of the disparities that we're experiencing, we pull our data and it's full of gaps. It doesn't paint the whole picture, which is holding us back. It's hindering us from delivering the services needed to our people. Data is paramount to quality health care and paramount to delivering those types of services. I think in the future, we really need to consider thinking about pulling these different entities together that are collecting data on Indigenous peoples and creating a central bank maybe or something along that lines. I know myself, I am working with the South Dakota Department of Health on a data sharing agreement. And that's something we're going to come to you, Mr. Klein, to and have your entity look it over and see how we can streamline this and make this effective and make it a model, or maybe somebody's already doing it. I have no idea. But I know the state doesn't play well with us. They won't share data. They won't share resources. And so in the future, moving forward, we need to prioritize protecting tribal data or centralize it so that we all have access to it, and support and acknowledge tribal data sovereignty, which is paramount. Again, I repeat, paramount to healthcare, quality healthcare. Data sharing agreements are nothing new. But when it comes to healthcare, there is great difficulty in putting those agreements together. It's our data. It's ours. That belongs to us. So we would appreciate any support, acknowledgement, anything to help us get to that point, to where we can paint a full picture for you and give you the all details of what's going on there, because you guys don't know. You look at the data full of gaps and you think you have a picture of it. You don't. I appreciate you. Thank you.
Vice Chairwoman.
Hello, I'm committee member of the Port Sil-Chiricahua Springs Apache Tribe. My name is Naomi Hartford. I just want to start off by saying I think this is an incredible opportunity, incredible conversation. I think you kind of are gathering that by the more that we discuss it, just how deeply impactful these things can be. It does not get lost on us. We know how powerful data-driven research is. We are behind in best practices, among other things, being able to implement these things and serve our communities properly. Chairman made a statement about data possibly being used against us. It is not a potential, it does. Let's see, let me clarify that. I don't believe this is malintentional, but the effects are just as devastating, and there is a reason for this. If we don't have advocates on the front lines of these conversations, a lot of times the perspective and the view of what this research and what these conclusions are misrepresented because of the gaps, and the folks in our communities are the ones that make the true difference in understanding where this research needs to be driven. And I appreciate that point being brought up by a lot of us, that education, we have seen generations of change of what truly changes and makes a difference for us, and it's having those advocates behind the scenes. Let me get back to where I was, sorry. We have generations of experience in it, of this misrepresentation. And it changes, and this data being used against us, it changes and evolves with the time. So totally restructuring how we approach this is the only way that we are truly going to make a difference and utilize this opportunity in a way that works for us and has all of these points that you all have brought up truly going to happen. So we've seen that these models that are already existing do not work in our communities. And how do we change that, right? So here's the other point that I think we've all been kind of coming together and reiterating, because we all have that experience with it, right? We have to be brought in early on in the conversation. Honestly, we need to be able to lead these conversations, and we hear it all the time, right? We're going to be brought in the beginning, but to truly do that, we know the difference and we know the impact that it could truly have, and people that lead and direct these opportunities are the ones that are going to make that happen, and we understand that. We've all dealt with it. Without understanding our communities, this data and research can be detrimental. We need to discuss and investing in tribal education, and I don't think it should start at university. I think it should start early on, early childhood education. A lot of these people that get into research have some sort of exposure, some sort of something that leads them to that. So because we are so behind, we need some real funding and effort going towards that early education, helping our youth be empowered, be taken seriously when they're at these tables. I have somebody in my community that is a brilliant researcher, and she time and time again gets either utilized as, unfortunately, I hate to say this term, but a token. And we watch it all the time, especially as Indigenous women, correct? So they don't really get seen because we think and we view it differently, right? We don't hit the status quo of how these processes are structured or how we analyze data or seeing where we want to lead the research, then we get seen as not as valuable or understanding how it works. But in our community, it doesn't work, and it's shown time and time again, right? We get these huge gaps. So also another point that has been brought up, what is data sovereignty? A huge takeaway. Please, please, if you hear anything today, if you really want to make a difference and you really want to truly learn what data sovereignty is, ask us. Start with that conversation. What does data sovereignty mean to you? And we are experts, and it's not just, it's a survival, right? It's something that has harmed us, and it's a ripple effect of harm, right? It continues, and it's one of the most harmful things that has been done to us. And if you want to understand, and in a good way, right? A way that we can really work together and bridge these gaps, save funding, early intervention, reduce costs. Creating jobs and reducing costs is what Indian country does. So anyhow, I just really appreciate the conversation, and I'm very excited, and I hope we can do some really good things.
Okay, I'm going to try to have this wrapped up by noon, and so keep.
I can do that. Good morning. Good to see you again, Dr. J. Lonnie Greninger, Vice Chair for the Jamestown Slalom Tribe. I have a comment specifically for your CDC hat, and then a comment for all three of you. On the CDC side, we had the Real Food panel yesterday, and I was really hoping CDC would be here too, because there is the Healthy Tribes program that currently funds some traditional foods grants, and so I did bring that up yesterday as something that tribes want to see continued support for. I know that it was on the chopping block last year in the president's budget, and tribes really fought hard for that, and we kept it in. I see it's on the chopping block again, so tribes are going to keep fighting for that program, but I want to make sure, Dr. J, that you know that that is an important, very important program for our tribes. So you have the TIPWIC and the GWIC that are specific to addressing physical activity, nutrition, and obesity. The third program under Healthy Tribes is also just as important. It has to do with epidemiology centers. So I want to support that one too, but since we were focusing on food yesterday, I only brought up those two. But the whole three programs of the Healthy Tribes Office, I want to make sure CDC protects that and keeps the funding moving forward. Okay, so that was CDC. Now your other hats. One of the things I wanted to reemphasize is this theme of evidence-based practice versus tribal best practices and data sovereignty. And then I also want to pull it into our tribal ways and our traditional healing services. I'm not as familiar with your two offices. Sorry about that, guys. But I am wondering, between the three of your offices, is there funding available for tribes to get our practices, our traditional healing ways, our cultural ways under evidence-based practices? Because to us, we have the evidence. It's just not westernized data, right? We have data in different ways. And I do understand I'm bringing up traditional and cultural ways, which are very sensitive when it comes to Western data models. And so that's where data sovereignty is going to come back in, is if we're going to do this in partnership with the federal government, knowing that we've had a hard past with data being used against us before. We don't want that weaponized against us. We want data to show and prove that our ways have been working for thousands of years, and they continue to work they'll work for the next thousands of years, right? And they do make us healthier. And so having data to help us bring those tribal programs into the evidence-based realm to have us taken seriously would be excellent. And I know, Dr. J, you and I have had an energized conversation about this. It was like a year or two ago. Like, we were excited about this, and there were some opportunities. I believe your staff were there with me. We were trying to think of ideas and what current opportunities there were. So I'm just wanting to keep seeing momentum for that moving forward. Thank you.
Okay, so there's a lot. So let me just go quickly because there's not much time. First, there was a question about the 3% set aside for public health infrastructure grants. We are absolutely at the CDC very interested in having the tribes consulted and participate in how those are dispersed. That's actively ongoing right now, and so you'll start to see. I mean, in fact, you probably already have seen some consultation around that. It's about $10 million of money. It's congressionally mandated, but there's also other monies that were previously allocated that we're going to continue to allocate. So it'll end up being more than just the 3% for this year, anyways. We've prioritized making sure that we hear from the tribes regarding how that money should be allocated, and Damien Kilsback at the OTAS office has been on top of that. So if you have any questions about the CDC, please reach out to Captain Kilsback. All right, let me. Sorry, guys, I took so many notes. Tribal data sharing policy. That, as you know, is tremendously important to us at the NIH. We've worked very hard to make sure that we listen to the tribes. Over the last year, we've had a dozen listening sessions regarding tribal data sharing and particularly sovereignty policy regarding tribal data sharing. And so that's resulted in things like our indigenous biospecimen policy, where we return biospecimens that the NIH has at the request of tribes. We have a process set up to make that happen. And we're going to keep listening. This is something it's a policy that we're working on. We should have some, let's say August-ish. I mean, I shouldn't promise because it ends up like the government moves slower than you always government slower than I think. So, but we're based on those listening sessions, we're going to have some policy relatively soon. The tribal epicenters. So both the CDC and the NIH are working to gather information on these tribal epicenters to see how we can improve support for the centers, including addressing the health and tribal decision-making needs of tribal nations. Again, this is one of those things where I know for a fact, I've heard so many, the common theme was that data drives better decisions. And we can't get the data without understanding the tribes, without you all participating in it. So it's an invitation to you all to continue, and the epicenters are a tremendously important part of that. So we're gonna keep both the CDC and the NIH continue to work on that. I heard a question about the cancer, the support for cancer research at the NIH for tribes. So first, let me just say that we are absolutely committed to that. I mean, I am aware of the very high rates of cancer death in tribal communities. It's something that how do you make America healthy again without addressing that? Our Cancer Institute, National Cancer Institute, is absolutely committed to that. We have tremendous programs that involve tribal communities. One of the requirements for the National Cancer Institute designated cancer centers is that there is outreach to rural communities. If you're going to be a designated cancer center, it's really vital that you shouldn't have to be very close to a academic medical center to be included in trials. And so we have requirement that there be satellite campuses. I went and visited the University of Oklahoma to see, and there's a lot of collaboration with the University of Oklahoma and the tribal communities. It's of course there's ways to improve that, but I'm absolutely committed to that. Regarding NIMHD, I know that there's the Tribal Cancer Center housed inside MIHD. I'm personally going to make sure that is, no matter what happens to the budget, that's a priority of mine to protect. I can't control everything, but that's something I'm absolutely, because I've seen the huge improvements in health that come from that program specifically, and those programs generally. Regarding the staff at the throw office, I'm working on it. I've heard from Corinna Walters about the couple of staff, and we're gonna work to. They were on administrative leave. We're working with HHS to make sure to have them come back. Especially since I've detailed Corinna over to CDC for half-time. We really need the extra staff to make sure that the NIH is well staffed. So we're going to work on that. I can't promise, Lonnie, someone wanted to double the throw office funding. I can't promise doubling, but I do know. But you've heard. I hope you hear my heart on this. Like there is it's really important to me that the throw office succeed. I've learned a tremendous amount. It's made a huge difference in the programs at the NIH. One of the things I'm working on at the CDC is that the OTASA office, which should be in the Office of the Director, is not currently in the Office of the Director. It's sort of underneath the Public Health Infrastructure Grants. I've seen firsthand how important it is to have the row office in the Office of the Director at the NIH. I'm working to make that happen at the CDC, so the OTASA office is elevated to the Office of the Director. All right, I'll stop and let my colleagues go. I'm sorry.
Yeah, so I heard a number of themes here, and so our agency ARC is small, and what we do is we're focused. We do a small number of things, and we try to do them extremely well. And really, we're dedicated to improving outcomes. And so I think there's a lot of room for partnerships here. Okay. And so in terms of data, we're already starting to work with you on data. And sovereignty, we're not trying to take anybody's data, and we certainly want to use it to help, not to harm. But what we want to do is to work with you so that to help you collect and manage your data, to help provide and build the type of systems that we have already in existence with states. And I think it's it's an obvious point that if you can't measure things, you can't address them. And I think that developing high quality data is something that we're quite good at, and within the scope of what we do, we should be able to help make an impact. And I know we're already starting, and we start to embark on data projects, and I really look forward to moving forward with those, because I feel there's a real opportunity to help solve some of the problems that you're suggesting. We can't manage all your data. We're not NIH. We're very small. But again, for example, in collecting hospital data, we're extremely good at it, and we can help you collect data and help in the analysis. Another topic was evidence, and that's another area in which we're very, very good. Even NIH uses us to do evidence synthesis. So some of what I'm hearing is for Lonnie, for example, is data gathering. So maybe studies and that sort of thing. We're not as much engaged in generation of primary data as we are in synthesizing data. But I think there's a lot of room actually to help in this area. For example. So there was a mention of cancer. So for example, a systematic review on colon cancer screening interventions in tribal communities. What's the best way to go about it? What works? What's the evidence that we have available on how we should proceed? Opioids, obviously, a major problem. And of course, opioid use disorder is treated with medications. So what's working and what's not working, and how do we go about finding the best ways to address the problem in the settings that we're describing in your settings, rather than sort of generic talk. And then I've heard some talk about safety, and we're quite good at also in patient safety. Again, some of these types of projects I think would tend to be more specific and kind of they basically be on kind of a topic specific basis. Again, and getting back to opiates, I've talked. We have a toolkit, for example, that helps bring opiate treatment into primary care, and that's a new toolkit, and it still is under development. But I talked to Dr. Kanan from IHS about it, and he felt that we could have discussions about how to modify it to actually, in its current form, maybe it's not going to be as effective in tribal settings, but he felt there are ways to improve it and to make it suitable for those settings. And there's the opportunity to do other educational materials like that on safety issues, on ways to address problems that would be focused and tailored toward your communities. And so I really look forward to this partnership. And thank you for the opportunity to be here.
All right, last and least, before I jump into this, guys, grab your phones, grab your pens. I'm going to give you my email address. It's really not that hard, but rafid.fadul, R-A-F as in Frank, I-D as in David, .fadul, F-A-D-U-L, at arpa-h.gov. This is my first time meeting all of you, and this is the beginning of a chapter. This is not just a one-time engagement, and we have a lot to talk about very clearly. So just to start there, and now let's jump into some of the specifics. Everyone talked about data rights. That was very clear. We are not a data agency. We are a research agency. We do the breakthroughs, but building that in, so Councilwoman, you brought that up. What is data sovereignty to you? We should have that conversation. So I'm expecting an email to talk about that. Moving to the concept, we talked about addiction, and Many of you may have heard over the weekend there was an executive order passed around the use of ibogaine and other neuroplastogens or psychedelic medications for the benefit of mental health issues, including addiction, including PTSD, including refractory depression. We have a program called Evidence, which has allocated over $140 million already towards this research. This addiction is a scourge. It's affecting society in ways that unfortunately have this negative reverberation throughout not just that person, but the families and the communities. And it's disproportionately hitting the Native communities as well. And so we have to take an effort there. And I encourage everyone here, we just launched this program, right? And we need partners in order to make this reach the communities that need it most. So the program is called Evident. I encourage you guys to take a look at that. You can also email me about that if you like. On the data rights piece, the other piece I wanted to say is that we have a program called BDF, which is building the tools that help share data across health systems and the health ecosystem. This is another one that affects everyone because it connects disparate communities. And so I encourage you guys to look into that as well and see if there's a role for participation. Is it time? Oh, is it time? Oh, I'll shut up. But the last thing I'll say is yeah, okay. I'm getting the flashing the light at me. Stephanie, I heard the pain in your voice as you shared your story, and I know that pain really well. My background is a critical care physician, and so I feel that. So first of all, thank you for sharing that. But the things that we're doing on that, we're not a policy agency. We're obviously the Breakthrough Research Group. But what we're doing to focus on that is really looking at ways to get early detection, early intervention, interventions at home. So those moments that you experienced and you described, I know exactly that moment that you felt. And I don't want anyone to ever feel that pain again. And I'm sorry that you had to feel that. So we're working on that as well. And the last thing I'll say, Lonnie, you know what they call traditional medicine in like 30, 40 years? They call it medicine, right? Exactly. So, let's not forget that aspirin came from the bark of a tree how many thousands of years ago, right? So we should have that conversation as well. Thank you guys so much for the time. I really appreciate the opportunity to be here.
That was a great way to close. Thank you. And I want to thank the panelists. Let's give them a big hand. They spent a little extra time with us. Okay, that being said, Devin, is the other group ready, or we kind of went too far? Okay, thank you. Gentlemen, thank you. And Ms. Yazzie, I apologize. All right, I seen it. Yes. Okay, first of all, let me apologize a bit. We ran later than expected. I thank you for giving your time and waiting here so that we can finish this panel. With that being said, we'll go ahead and start with Ms. Stanfield.
Thank you. Sharon Stanfield, Chief Health Officer of Government Affairs for Cow Creek, Umpqua Tribe of Indians, and I'm also a delegate to the Northwest Portland Area Indian Health Board. Quick question and then a comment for Sam. Is Samsa back? Okay, Sam, thank you. Wanted to make sure that the new funds, the 2026 surplus for SDPI, is going to have a consultation. So our tribal leaders can assist with where those funds, the 50 million, the extra 50 million, where those new funds should be directed.
Okay.
So the short,
Or do you want me to save you from this one? Because I think that's an IHS question, right?
Yes, sorry.
Same,
Yeah.
I was
Oh,
like,
sorry.
I'll save you for that one. Yes, so we're still looking at it. The team's working on putting together. I know they've been meeting very closely with, this diabetes committee, as you've been well aware. We're definitely planning on doing increased engagements. I have not talked to the team specifically about, dates, times, things, but definitely heard and received. Anytime we get new money, it is definitely a thing that we want to collect lots of feedback about and how to spend it. So,
Great. You appreciate that, since time's of the essence with this being year 5 and wanting to make sure that we don't lose those funds or they don't get wrapped into year 5. So thank you very much. And then for SAMHSA, sorry to confuse.
No, that's okay.
Just, you're trying to figure out how you were going to do that.
I was going to give the easy answer. Yes.
Sure, we'll do it. Just wanting to, a little bit from this morning to clarify when we were talking about grants with SAMHSA.
Yes.
And you've probably heard this, but in case you haven't, those are incredibly difficult grants for our tribes to write. We don't have, not all of us have grant writers, so many tribes lose out on those funds. At the Northwest Portland area, we're able to have them prepare the grant, and then sometimes we can do sub-awards, but a lot of tribes are losing out simply because of the grant process. So I wanted you to be aware in case you weren't. And then also, having the funds go through the state is not a great option for us. Often, some of our states don't work as well with tribes as others do, and that in itself, you can imagine, is a problem. But what we would really appreciate is to have with our own self-governance, to have those funds come directly to the tribes. So again, that's probably not an avenue that we've yet gone down, but that would be really good for the Tribal Advisory Committee. I'm sure they've brought it up to your agency, if we could have those funds directly. So thank you for your time.
Absolutely. Oh, so just a quick response to that. That's noted, so thank you for that comment. And I wanted to, which kind of ties into the conversation and discussion from earlier, just to reaffirm that SAMHSA's Office of Tribal Affairs and Policy does exist to be able to support and assist with exactly what you're talking about. So we do have pre-planning sessions and discussions, which most of those sessions are currently available on our website. And we disseminate and share information for any upcoming or future sessions as well. So what we're going to do is share the information that you can find on that currently exists on our website. And then we can speak after to confirm what's the best way to communicate out the information that you can then use to make sure that you're a part of those planning sessions and those discussions. So more to come related to that, but the goal is for us to be able to inform and have discussions before final decisions are made. Mm-hmm.
We have a question for Mr. Ingalls if he's able to come back. And so in light of that, would you like to start with closing comments?
Is that for me, Chairman? Well, likewise, we get to have lots of engagements together, so not a lot to reiterate, but I do appreciate talking about this when we really think about how are we going to improve the healthcare system. As we know, it's a multifaceted approach. It is a team effort. There is not a one-size-fits-all easy solution to these kind of challenges. We're committed to trying to do our part to do everything we can to advance the topic, and we know that you are likewise doing the same. So, Adil.
And Ms. Crocker, before you go, I want to just kind of go back and support a little bit of what Ms. Stanfield was saying and indicating about SAMHSA grants. Mm-hmm. One of the other areas that make it really difficult for tribes, small tribes, to go after SAMHSA grants that are really needed in the community is the size. And so because it's a population problem, it's hard to get funding that would support support a program that SAMHSA funds. And so we're trying to be really unique, and it's good that larger tribal consortiums are able to get it and provide services, but it doesn't always get down to the level of program needs. And so they go after the big grants. Big grants are really good. It helps the community and stuff. And I think that's, but it doesn't really, the community has a hard time having their needs met when another entity is trying to provide. And so if there's some way that we can be working it out where we can see how those smaller tribes can go after some of this funding and have enough of that funding to actually do something with, because a lot of the SAMHSA grants have a lot of administration burden too. And so, you know, and I like using the term, or the term came up to me, the STP, and a lot of the, and that's just meaning a lot of the smaller communities, they rely on the same 10 people to do everything in the community. And that makes it a little bit challenging. And so I just wanted to share that. I'm not trying to take away from the larger consortiums, because they're needed and they're able to get the population to get at least the services going out. But if more could be done for the smaller communities, I think that would be beneficial. Chief Allen?
Chairman Allen, if you want to respond to that comment first. I'm curious what your response is.
Yeah, I think the response is essentially the same. So working through our Office of Tribal Affairs and Policy is the key to that, so we continue to have those discussions and conversations. I'm very familiar with the grants process because grants management is a part of the Office of Financial Resources. And I will share that I have actually worked in the federal space. I previously worked with the AIAN Office of Head Start, and I've worked under ACF with ANA and many other tribal programs as well. So I understand the complexities and the challenges, and I've worked with many tribal nations to try to find solutions to a lot of the challenges. So it's not the first time that I'm hearing a lot of this. And so yes, SAMHSA is open to the feedback and the discussion and conversation so that we can try to find ways to simplify the process as much as possible and to open up eligibility as much as possible, at least within the authority that we have to be able to do that.
Well, okay, I appreciate that. So let me take this to a different approach. This is about budget. Our conversation is there's never enough money. I am a little frustrated and I want to hear your thoughts about, from the administration perspective, why we're not getting, actually not every 5-year reauthorization, but permanent authorization for SAMHSA. The challenges of dependency, drugs, alcohol, and anything else that become dependencies is not going to go away. If anybody thinks it's going to go away, it's going to be one, we're all done now. They're living in a bubble. So, quite frankly, tribes have, as Sharon has pointed out, what she didn't say is we hate grants. And what the reason self-governance is moving forward, because we want the resources just sent to us automatically, just automatically renewed. Now, it's never enough. You know, Navajo will say, you know, I got 400,000 citizens I got to take care of. Jamestown, you know, sitting at 500. Okay, so, but you have to come up with a system that prorates what we got available for our citizens. And it's not about data that you have, how many are actually dependent. Okay, I'll serve those. Okay, renew that data. Don't do that. It's a crazy way to do it. It's a problem. It doesn't matter whether it's alcohol, whether it's cocaine, heroin, fentanyl, or any of the other dependencies that are out there. Gambling is a dependency. So the issue to me is I think SAMHSA needs to think outside the box. this administration is saying we want to think outside the box. Quite frankly, we need to just have like the self-governance compact with all 575 tribes, a system that divvies up the money available that we can keep arguing for. We do want you to have resources in order to gather the kind of data that helps us understand the complexity of those dependencies, whatever they are. But at the end of the day, we don't want to spend the money that we receive or spend money to get the money, and so it's being counterproductive. So we have less money to work with. We want to be able to tackle the problem every day. And I mentioned earlier that I had to go figure out how to put together a opiate substance abuse dependency program on my own, without any help from SAMHSA, without any help from IHS. I had to just figure out how to make it work. And I will tell you that the reimbursement rate for bins and non-bins makes it work. Clayton, I want you to go to work on OGC, get those guys, get their act together, interpret ISDEAA correctly. We need SAMHSA to be a part of the solution here. Make it easier for us to fix the problem and tackle the problem. It's not going away on us. Every one of us have this problem every day. And so the granting process, like what Sharon was saying, and you've heard this before, yes, this is not a new gripe from our perspective. And so I just think that on a government-to-government basis, the administration needs to be proactive in order to tackle the problem within our Indian communities. This is a better system to do it. Now, I will, I am a bit of an advocate for urban settings, and don't take them out of the equation. So they need help too. But for tribes, we just want to basically get the resources available to us. Whatever the number I get, I will take that and whatever else I can get from any other source, state sources or community, county sources or foundation sources, and package it together. Maybe the tribe's going to add some, and then we'll have a program that works. Going to my point about my outpatient program, it worked. I had people knocking on the door before I was even open. We weren't even done with the construction. They were knocking, you open? I'm going, yeah, not yet. Give us a month. So that's the way to deal with it. And so I just want to say that I think I would encourage and urge you to look at a more creative way to get around the granting approach to getting those resources. I know you agree they're needed. I know you don't argue that point. But the system, we're trying to make the system work more efficiently so that tribes can get those resources. I just want to throw that on the table and hope that maybe you would encourage maybe a small work group to talk about how you can tell us what the reasons why not, or what the barriers are, legislatively or administratively, et cetera. Tell us what those barriers are, and let's work around them. We'll go to Congress with you in partnership to get them to make sure the statutes match up with the system that would work more efficiently. Thanks.
Okay.
I'll get off my pedestal.
Can I just quickly respond? Okay, so there are a few things in there. One, I absolutely agree that the application process for grants could be streamlined. There are certain things that we have been looking at internally to support and assist with that process. Part of that would be essentially going through a pre-application process, which we actually currently do. We have many pre-application webinars and workshops which we offer, and I would encourage people to take advantage of that. And then also, if you look within our notice of funding opportunity announcements, there are specific points of contacts. So when you have questions or need to support, because there are resources that might be available to assist with that process, and I encourage people to take advantage of those resources that would be available, so you can reach out to those points of contacts that are identified in the Notice of Funding Opportunity announcement for that. And then secondly, I also agree that part of this has to do with the legislative process and tying into the extending the performance and project periods associated with some of these grants and essentially kind of making it a little bit more indefinite as opposed to being termed. Partnership absolutely needs to happen surrounding that. And then finally, I think that is part of the intent of the new resources for Native Americans grant program, that the $80 million investment that we're proposing. That is essentially to be able to provide the flexibility that we hope that recipients would be able to then use to sort of come up and create the best program that essentially would fit whatever their needs are. But I am always available as a part of our grants process if anyone is looking at the notice of funding opportunity. My information may not necessarily be listed now. It was previously, if you were to pull up any of our previous NOFOs, maybe going back to 2023 or before, my contact information, I can guarantee, is probably listed in there. So you can absolutely reach out to any of the grants management specialists, the program staff identified in those NOFOs, and myself as well. And we can continue to have conversations.
One of the things, forgive me, Mr. Chairman, so Indian country is complicated, and the way we receive money is complicated. Your system has right now the granting process, but many of us do contracts, many of us do self-governance, many of us get direct services. In regard to SAMHSA has to complement what our program, how our programs are provided to our communities. We need to talk through that so you fully understand the complexity of how services are provided to the tribes and how they will complement how we receive services or provide services today. So we just need to get a better handle on it and navigate an approach that the administration would support, that we can persuade Congress to accept a new way of doing business. I appreciate all the help, to try to simplify, but Sharon's point, one of Sharon's points, many tribes don't have grant writers, and they just fall off the end of the bench. They don't get help, and they need help. That's not fair for them. This has to be an inclusive program, and not only those who have the resources to access.
Yes.
Because of the way the system works.
Understood. And that is where IHS comes in too. That's part of the design of the new program that we will be working with IHS, basically with every opportunity to try to structure this a little differently than the standard grants, a grant program. So we can share all the information that we currently have available. So others can, just be a little bit more aware and know and understand where we are in that process. But that's a part of the plan.
Okay, because of time, what I'm going to be doing is we have two in the queue. I'm going to go with those two. I'm going to let them respond. We're going to take a 5-minute break before we start a new panel. All right? With that, so I'm sorry, Vice Mayor. So with that, Ms. Yazzie, then we'll go with Council Member.
Thank you so much. As stated by my fellow colleague, I feel like we're in a box here, and we're all trying to fit according to the compliances of SAMHSA, and we're all different. The time frames do not work well with us. It's almost like saying, our term is almost ending. Are you well yet? I hope you're well. Hope you're well because our grant's ending right now. And as you know, in the journey of healing, it takes time. So to sustain a program, just getting away from grant funding and just direct funding would be most appropriate to a lot of our tribes. And I'm sure it would save a lot of administrative oversight on your end in terms of the logistics and the processes and et cetera. But I think it's important to note that addressing the substance abuses at our level is extremely essential in terms of the trauma that our people have endured to this day, and having a grant hinders expanding and improving treatment for our communities and the services that we render. So it's important to note that we really need to get away from grants. It's no fun. As stated, we don't. The nation is large. However, we don't have grant writers either, and it's critical. And I can imagine what it's like for other tribes, nation, and pueblos who don't have grant writers. So that's one of the echoes and reiterations that I wanted to bring up on behalf of Navajo, is if we could stem away from grants and just really work towards distribution of funds, that would be critical. Thank you.
Okay, Mr. Cutts.
Hi. She said much of what I wanted to say. What I want to say is stable funding, and when you deal with small rural communities and you put a number on it, the number needs to be what's it take to get a staff person there to do it, that lives in that community and can do it. And if you get a grant that's short term, that might only be 1 or 2 years, that isn't going to stabilize anything in the community. So look at that. Rural communities in Alaska far apart. You know, sometimes there's some there that could go together and do something together, but most in these isolated communities, it's going to take at least one person there doing it.
That being said, we're going to go ahead and get wrapped up. So final comments, if you have anything you want to add, and Mr. Ingalls, if you would like to have closing comments.
Sure. So I just want to say thank you again for the opportunity to even be here. I'm actually very thankful that Chris Carroll did not make it today, because then I got the honor to be here and assist with addressing questions. I would just like to express that SAMHSA is open to conversations beyond these sessions. Again, you can connect with us through our Office of Tribal Affairs and Policy. Carrie and Kim are both here today. I am available after if anyone would like to come and we can meet directly, and I can share any information that would be helpful to you, and we can continue our conversations beyond this. And just again, thank you for the opportunity.
Thank you, Mr. Chairman. I do want to address the governor. And Mr. Chairman, I apologize. I should have made a comment. I do respect what you had to say, and I do respect the passion that you put forth for your members. And I would like to take an opportunity. I was just in Arizona because could have hopped on a plane and just came over to visit you. But I would like to have an opportunity to come down and visit sometime. You have a beautiful area of the country, and I would like to come back sometime. But to all of you, I want you to know the door is always open. We want to have a chance to meet. I did just have a chance to meet with my friends from the Lac de Flambeau. But I do respect the nation-to-nation representation that we have, and I want to keep that going. So thank you very much for this opportunity today.
I think, just to reiterate what Tom said, similarly, Governor, I didn't have a response because I think you said a lot. You said it all. A lot of it was wrapped up in your statements, and didn't want to take away, but we do appreciate you. And I'm sorry we didn't see you when I was in New Mexico just a couple weeks ago, so apologies. Amen. I made it all the way to Santa Fe. We were in Albuquerque staying, and we had one day layover before we headed to Alaska, and I think I drove all the way to Santa Fe to hit some Cafe Pascal downtown Santa Fe, but you have the best food down there. It's horrible for my waistline, but don't tell the secretary.
I want to thank you. Just for the record, we have something we want to make sure that's added, and so Councilmember Cutts.
Yeah, we had some comments we wanted to get to Administrator Ingalls around HRSA, HPSA scores, HRSA, and some other things, and so I think we'll prepare some written information for the record on that. Thank you.
Okay, I want to thank you once again, and thank you for adjusting your schedule today. That's much appreciated. Let's give him a big hand. Okay, you all now have 8 minutes. Run.
Enjoy your lunch. Produced by the U.S. Department of Health and Human Services.